Morning, everyone. I'm Barry Borman, and I welcome you here to the 2023 PHONZ online conference. We've got a wide range of esteemed presenters in the next 3 days. I'm sure you'll enjoy that. I'd like to thank the members of the steering group for helping to put the program together, and of course Patrick, who'll be managing the IT for this. Once again, thank you to all the speakers that have given up their time to present on important topics of ethics, implementation and communication. We have a couple of recorded recordings which we will put through. Firstly, Ashley Bloomfield. One change to the program is that Chris Galloway will be speaking before Angela Ballantyne, so that's the only change that we have. So once again, my pleasure to welcome you all here to the PHONZ conference, and I'll now ask Tim to do the karakia.
Thanks, morning. Thanks, Barry, and haere mai, everybody. Mi karakia tātou, whakataka te hao ki te uru, whakataka te hao ki te tonga, kia makinakina ki utu, kia mātaratara ki tai, I hei aka ana te aka kora, ti hoi hi hoka, hei hu tehi Māori ora. Kia aka nui kia aka rau, nā mahi, kia katoa tia mai, kia mai ki tēnā hui o tātou, o te rapu matu hauora, papa ora o Aotearoa. Tihau ka inga ngātu tū rangatora, Taranaki whānau, tia mahi kia kātou. He mihi, tēnā kia rātou kia whai tūrangi wai, kia tā kōwhai o Ranganui, mo mai rā kātou. Rātou kia rātou, tātou tia tātou, tēnā koutou katoa. Kia ora, everybody, and welcome to the PHONZ conference. Back to you, Barry.
Good. Thank you, Tim. And it's now my pleasure to introduce somebody who actually for New Zealanders requires no introduction, and that's Professor Sir Ashley Bloomfield, who was, as you'll remember, the PHONZ person during the COVID. Everybody remembers him. Ashley has given us a recording to open the conference. Unfortunately, fortunately for him, he's travelling, I think, in Europe, enduring a heat wave, but well protected, I'm sure. So Patrick is now going to play Ashley's welcome. There is an opportunity for questions. We'll do it through the Q&A, and as Ashley's not here, we can actually ask him to, he will reply to those direct through the Q&A later. Thank you, Patrick.
Well, kia ora koutou katoa. No mai haere mai. Welcome to the PHONZ conference. It's a great pleasure for me to be speaking and being with you, even if it is virtually. And I'm really thrilled that I've got the opportunity to open the conference. I want to start by just wishing you all the best for the next 2.5 days. I've had a look through the program. It looks fantastic. Some really stimulating, interesting, a wide variety of topics being addressed. And I want to also thank you for your work. It's just fundamental to improving health and health systems and health outcomes in New Zealand. And really took all the work you are doing, and I hope I can, in my new role at the University of Auckland, work with you more closely to progress it. I wanted to just cover 3 things today in my opening comments. The first is just again to emphasise the absolute significance and importance of public health intelligence. And for me, if I reflect back on my time as Director General of Health, not least is the sort of the public health face of the COVID pandemic and the government's chief advisor on the response to the pandemic. Intelligence was just such a critical part of our response, and the fact that we were able to gather and interpret and communicate that intelligence was fundamental to, I think, the success that New Zealand had as a country. And for my part, when I had to stand up in front of the cameras every day, and it never got any easier, over 300 stand-ups, knowing that I had the absolute best information that was available at that time from a whole range of sources. And of course, not just the data, not just the latest research and evidence, not just the knowledge, but also the intelligence gleaned from that. In other words, that key question, what does all this mean? And my job was then to take all those data and try and communicate those to the public in a way that provided them with, first of all, information and understanding of what was happening, and then also clarity around what they needed to do in response. So intelligence was fundamental to our successful COVID response, but right through my public health career, and I've spent most of the last 25 years in central government at the Ministry of Health, working at that sort of policy interface, that political interface, and given my background in public health, of course, data and information has been fundamental to the advice I've been giving. And if I reflect, for example, on an area that's been, part of, very dear to my heart for that time, and that is tobacco control, and just how important data and evidence and information was early on in that journey 20 years ago when I was working on it, and the progress we've made now, where we are, if not on track, very close to being on track to achieving our aspiration of a smoke-free 2025 Aotearoa. That is an adult smoking rate below 5%. We're already below 10%, and it's been wonderful to see a big reduction in those inequities in smoking rates, those different smoking rates for Māori and Pacifica, which have really dropped a lot over the last few years. So data and intelligence is just fundamental to the work I've been doing for the last 25 years. It will remain so, and I'm really looking forward in my new role to think about how we can strengthen even further the tie between those generating the research, the data, the intelligence, and those who are providing the advice and making the decisions in the policy sphere. Second point I wanted to make, and this is really relevant to the stage I find myself at and New Zealand finds itself at now, post-pandemic, that we go back and review and look at what happened. And of course, again, this is where we can use the data, the intelligence that we had during the pandemic, but also what we can look at now. And, perhaps one of the indicators that means I can sleep well at night that I hold in my mind is the indicator around cumulative excess mortality. We're in New Zealand 3 years on from the start of that pandemic, the only country in the world where we still have negative excess mortality cumulative over those 3 years. And again, if there's no other indicator about the success of our response, that's got to be the key one. But it is important we go back and take a look, and this is really important in terms of research and evidence and intelligence, that it's never a static thing. It's always dynamic, and certainly for us during COVID, it was daily we were looking at what was changing. And I certainly remember well having to front those media stand-ups where things hadn't gone well. And I joke about the fact on those days I was flying solo, instead of myself and the minister or myself and the Prime Minister, I would be giving the update by myself because something hadn't gone right. And the media, of course, love this. Their favourite F word, failure. So they would lead out with the headline. One of them, when this happened early on, in 2020, actually mid-2020, it was the first major stuff-up, you could say. And the headline from Stuff talking about me said, "From hero to zero." Now, I hadn't thought of myself as a hero, so I didn't take it personally. But, the media loves it when things don't go right, and they throw failure around liberally in their headlines and their stories every day. The way I would deal with this is just to point out to them, actually, things never go according to plan, even the best laid plans. And there's a saying in military terms that the very best strategy is fantastic until the first contact. And so it has to be informed by what is happening every day, what is happening on the ground, and using new intelligence. So it's important we go back and review and learn and adjust so that we are even better prepared next time, and we take on board the lessons of what we have learned, both the good, the things that went well, and the things that didn't go well. So I encourage you to be thinking about that in your own work. Again, intelligence is not a static thing, it's a dynamic thing. And my final point is just to reflect on the health system environment that New Zealand has at the moment, and the big changes that are happening there with the establishment of a single national Health New Zealand, that is Te Whatu Order, the establishment of a Māori Health Authority, Te Aka Whai Order, important developments with real potential to create a more unified system, and indeed one that is even better able to address inequities in health, particularly for Māori, and to address Māori aspirations for their health and well-being. But it's not easy, it's not straightforward. Intelligence, data, insights are going to be absolutely fundamental to us being able to ensure that those changes actually deliver better health services, higher quality health services, more equitable health services for New Zealanders. And so I encourage you to think about ways you can contribute to that. And two things from the pandemic that I think, if we can carry those through into the new system, will stand us in good stead. The first is, and I've referred to this, a sort of a renewed respect for the role of public health intelligence, of data, of knowledge in informing decisions, and just how critical it is to making very good decisions. And so, you know, in a sense, public health is in the limelight. There is confidence that we have got good people in this country, that we can do really good work through our surveillance work, our other public health intelligence work. And so it's important we use that opportunity and we don't lose that opportunity. But the second thing is the confidence there is now in the health system's ability to actually improve data and digital systems to be able to respond rapidly. And if I think about some of the incredible work that was done during the pandemic, early on to establish a contact tracing system out of nothing, of course we had to set up 3 or 4 new systems that all needed to link and all needed to generate and use good quality data to deliver our vaccination program, that were able to provide data on a daily and weekly basis about where we weren't having success, so that we could adjust our program, you know, where we weren't reaching into population groups, young Māori, rural populations, so that we could do different things. But what that did give was, it gave ministers confidence that the health sector actually, if they put the money up, we did have the capability and capacity to develop and improve over time these systems, in fact over a very short period of time. And I think that confidence and the funding that has flowed with us means that in the future our health system will better be able to generate good data, but most importantly make those data available to those who need them to make decisions, whether those are members of the public, whether they are health professionals, whether they are health planners or policymakers and politicians, to have a better system in place to be able to use the data that is there and that is so important for us to be able to improve our health system, to improve the quality of care, to reduce inequities, and of course to continue to improve access to services. So wishing you all the best for this next 2.5 days. Make the most of it, and I'm sure you will take home many good things that will help you in your work, and I look forward to working with you all in future. Kia ora.
Well, thank you, Ashley, in absentia. And has anybody, we've got some time, has anybody got any questions that they would like to raise now? We can do that. Otherwise, does anybody have a question? I think that's a wonderful start to the conference, having somebody that's worked at the coalface, both in the political sense, but also working under a great deal of pressure. And I think that's a wonderful start. Oh, good. Thank you, Gray. Okay, well, now it's, we'll move on to our first international guest speaker, and it's my privilege to welcome Professor Lisa Lee, all the way from Virginia Tech in the USA. Lisa is Director of Scholarly Integrity and Research Compliance. She's an epidemiologist, bioethicist and ethics educator. And Lisa, won't mind me telling everyone that she's been to New Zealand a couple of times, and we're privileged to have her, and she spent a great deal of time at CDC. And for anybody interested in surveillance, Lisa is the lead author in the textbook on surveillance. So anybody wants to know about surveillance, that's the book that you go to. So Lisa's going to talk to us about the ethical dimensions of public health. So welcome, Lisa. Welcome to PHONZ, and the floor is yours.
Thank you so much, Barry. It is such a delight to be here. I'm going to start just with a few introductory comments, and then I'll share my screen to get our slides going. I really just want to thank you again for the invitation. The work that you all are doing in this conference, now I understand is your second online PHONZ conference. The theme for this year's conference, Public Health Ethics, Implementation, and Communication, captures what I think much of the public health community across the globe is discussing as we are thinking about the effects of COVID-19 pandemic on our profession. Cases of COVID-19 were caused, we know now, by a highly contagious, rapidly mutating respiratory virus with asymptomatic spread. But that wasn't it. The virus had help by way of the convergence of a number of social and political factors across the world that exacerbated this rapid spread of this infection and the loss of over 7 million lives. Now that public health is looking forward, we're learning lessons, we're thinking about how we can be better prepared to identify and respond to the next public health threat that we might be facing, while also maintaining all of our other essential services and interventions. So there are three, I'll share my screen now. There are three important themes, I think, that are growing out of there are three themes I think that are growing out of our field's reflections on COVID-19. And the first, I think, is what many of us here are very concerned about, which is the effective use of data. How can we harness the benefits of the datafication of our lives to more effectively develop and implement public health services? The second theme I think we're thinking a lot about is transparency. How can we ensure that our public health messages are communicated clearly and effectively, even when we're experiencing a great deal of uncertainty or perhaps scarcity? And finally, the third theme I think we're thinking a lot about is, what are the ethical foundations of our field? Before we develop, implement, and communicate our interventions, how do we approach the work with an ethical lens to ensure that what we do reflects not only data and evidence, which are clearly extremely important, but also reflect the public health values and principles, as well as the lived experience of communities that we serve. So I'm going to provide a few minutes providing some remarks about this last point, how public health professionals can identify and incorporate into our work those health values and principles, and consider the lived experience of our affected communities. I'd like to then follow my remarks with a discussion with you all about your thoughts about how we as public health professionals can operationalize these ideas into our work, into our day-to-day work in public health generally, but also in public health surveillance specifically. So as I present, if you have questions or thoughts, as something comes up and it stirs something in you, please type your thoughts, observations, etc. into the Q&A function or raise your hand, and we will then be ready to have discussion at the end during the discussion period. So some of what I'm sharing today evolved from a recent keynote address I presented at the 2022 meeting of the American Public Health Association, which was last November. And so I'm delighted to share that and a few more thoughts with you. So let's begin. All right, title of my talk, Ethical Dimensions of Public Health. What are these? What does this mean? We're going to do a poll. Our first thing here is we're going to do a poll, and we're going to talk a little bit about what public health's ethical lens is. But before we do that, I want you to think about, and Patrick, you can go ahead and put the poll up. I want you to think about, what is the first thing you think of when I say the word ethics? We're going to make a word cloud here. Patrick's is, okay, I see you've got, yeah, yourself. So what are some other things you think of? And don't think too hard about it. Just what are your basic responses here? What do you think of when I say the word ethics? Give you a few minutes to populate our cloud.
Yeah, so for the benefit of anyone who's not used one of these Mentimeter polls before, if you go to the website at the top of the screen there, menti.com, and enter that code, you can, or you'll have the opportunity to enter a response. And as your responses come in, they should start popping up live on the screen.
Good. Right. Some good ones coming up. Keep them coming. Mm-hmm. Okay. Looks like a variety of perspectives here. A couple more coming in. Good. Moral rules, safety, fairness, awareness, moral rules and oversight. Good. I'm trying not to laugh too hard and chuckle too much about the word dry on there. So I'm very interested in what that might mean for folks. But I hope that well, by the time we get through this, you'll find it more interesting than dry. All right. Okay. Excellent. We've got many different ideas here. What's right? What is the right thing to do? What's fair, for sure. Safety, hugely important in public health and safety. Responsibility and accountability, perhaps. Oversight and awareness, really important things. You got to know what you're supposed to do in order to do them. Do the right thing. Respect and honesty, critically important when we talk about ethics. Principles and moral rules, all of those things are things that we care deeply about when we talk about ethics. Now, I'm sure that, and I think the word cloud showed, people think about different things when they think about ethics. Sometimes we'll get responses like the ethics review board or research ethics or informed consent, these kinds of things, or the variety of things that you all said. And while we each think about different things when we think about ethics, what I hope happens after this session is that all of us leave here knowing what we, and by that I mean the profession of public health, thinks about and means by ethics. So keep in mind what you're thinking, and we'll talk a little bit what we think the profession thinks about. And as I wrote about many years ago, it's often the case when I speak to public health professionals about ethics, I hear comments that some of you might be thinking right now, like things like, of course I'm ethical, I work in public health. I mean, if I didn't care about social justice and I didn't care about health disparities, I would be in the private sector making big money. So clearly I'm an ethical person. And I will say that after decades in this field, I have absolutely no doubt that most of our colleagues are in fact very mission driven, and when faced with a choice between right and wrong, would choose right. I have no doubt about that. But that's not all that ethics is. And it's certainly not all that public health ethics is. So most of us are aware that there are many different flavors of ethics, right? So we have bioethics and medical ethics and legal and regular old ethics. I'm going to talk a little bit today just to set the stage for all of us, so we're all at the same start line here, about different types of bioethics, so different subfields, if you will, about bioethics. Most of us in public health are very familiar with research ethics because in public health often we do research, and also in clinical ethics. And clinical ethics because we are all at some point in our lives a patient, right? So we have a healthcare provider and we expect them to be ethical. So I'm going to compare and contrast a little bit about the differences between these fields and how that drives differences in ethical considerations. So research ethics, clinical ethics, which some people call medical ethics, and public health ethics are all subfields. They differ because research, clinical care, and public health are different from each other. Different motivations, different requirements, different obligations, at least in most liberal democracies. When we're doing research, we think about the unit of concern. So that's the first line here. And that's the research participant, the person we are asking to enroll in a study or to give us information, the person that takes on risks for the benefit of other people. Now, when we ask research subjects to take on risks, say for a new drug or some new intervention, we ask them not because they're going to get benefit, but because we're trying to figure out whether a treatment or an intervention will work for other people, or for communities in the future. By contrast, when we talk about clinical ethics, we're really talking about a unit of concern as the patient, the individual who's sitting across from the healthcare provider at that time. And that person might be taking on some risks, to be sure, but they're taking those risks on for their own benefit. So, for example, if an individual patient has to decide, are the side effects of this particular medication are the harms, in other words, worth the benefit of the cure? So everything is within that individual person. Different still is the unit of concern in public health. Here, the patient is the community, the collection of individuals whose health and well-being we're trying to optimize. So let's consider now the different approaches to how we actually achieve success in these various fields. So again, we're looking at approach to action here in the table. In research, we intervene with experiments or data collection, all in an effort to figure out how to do our work better, which thing works better. In clinical care, we intervene with treatment or pharmaceuticals or surgery, for example, after an illness has occurred. And in public health, our focus is on prevention of illness, hoping that never happens in the first place. And we use different tools to do this. We use policies, we use sanitation, we use behavior change and other methods. Now, because of these differences in research, individual clinical ethics and public health ethics, the ethical concerns of what we worry about are different. In research and clinical medicine, autonomy is king, right? In addition to the fact that we want to, optimize benefits for individuals and minimize risk for individuals, we worry mostly about an individual person giving consent to either participate in a research study, to provide data, or to get individual treatment. Both of these fields nod just a little bit to justice, but generally it's not the primary driver. In public health, on the other hand, we do have to respect individual autonomy, and we worry about disparities and we worry about vulnerable populations. We also, we respect individuals, we respect communities, we respect ecosystems. In addition to that, we have to recognize, and we do recognize, the interconnected nature of health, that the health of animals and ecosystems is a primary determinant of the health of humans. And in addition, justice, in particular social justice for public health, is a foundational value of our field. Now, if we didn't understand the differences in all these things before the COVID-19 pandemic, we surely know it now. Where the pandemic hit hardest, that is in the US, Central and South America, and Europe, it forced us to recognize that even the most straightforward seeming decisions in public health have ethical dimensions. It showed us that the intensity of determining what the right thing is to do in the face of uncertainty and involving evidence is extremely challenging. And it showed us, quite unfortunately, how political priorities can interfere with public health action. Now, the degree to which these things happen varied across countries and such, but it is certainly the case that these things had great impact in how we coped with and succeeded with dealing with COVID-19. In addition, it forced us to address moral distress among public health workforce. That is, distress that arises when a professional is asked to do something, or worse, required to do something that they know is counter to their profession's best judgment. And we've certainly seen a lot of that in the many people deciding, at least in the US and Europe, to leave their public health posts. So what exactly is public health ethics? Well, I think of it as two things. I first think of public health ethics as a noun. It really is the moral governance for public health. That is, it's the constellation of values and principles that motivate our work. Values that include things like equity, respect for human rights, community engagement, the common good, solidarity, and justice, amongst others. Public health values recognize that we share this planet with 8 billion other people. Just a couple of weeks ago, we're up to 8 billion now. And we must, because of that, we must recognize that we've got to consider the merits of many different values. We must recognize that while there are some common things that we all value, regardless of where we are and who we are, there are differences in how we define what is living our best lives. And because public health is public, we must acknowledge and make room for many of these differences. The second thing I think about when I think about public health ethics or defining public health ethics is that it's a verb. It is a way of reasoning through ethically challenging situations. It's the application of a decision-making framework that helps us determine a course of action when either values conflict or there's tension about two or more things that we care about. And often our choice is not a simple right versus wrong. How do we decide, for example, whether closing a business makes the most sense from a public health perspective, but is extremely dangerous from an economic perspective? We have to weigh the health safety and the economic safety, which is not always an easy trade-off, which we certainly learned in COVID. And because public health is a field of action, we actually do things in public health. Yes, we observe and we collect data, but we do things. We respond to those data and do something. And we have to act even when we're faced with really several not great choices. We've got to pick one and we must do something. More likely, though, in public health, we're faced with several right options, each with its own pluses and minuses, and we have to weigh the moral valence of those pluses and minuses and decide what is the best course of action, given what we know right now. And we must make all of these decisions transparently. So it's in situations like these where values conflict that it's especially important for us to do more than just kind of go with our gut or do what we think is the right thing to do. The public health decision-making frameworks we use are based on what our profession values, like what I talked about earlier, our moral governance, and these are really important for all of us to be aware of. So why doesn't kind of going with our gut or doing what we think is the right thing to do work as a method to decide something in public health? Primarily, it's because in public health, we're dealing with a public good. We've got to shift from our own individual moral compass to the collective. We've got to move from our personal sense of what's right to the moral compass of our profession. And this actually reminds me of a statement I heard many years ago while working at the US Centers for Disease Control and Prevention. We were concluding a site visit from ALAP, which many of you might know is the international body that accredits organizations that do work with animals. And during our exit conference, we were having a discussion. Some people might call it a heated discussion, but we were having a discussion about differing professional opinions about how to care for a particular species of animal. One of our reviewers, Dr. Jim Swearingen, said something that has just stuck with me for ever since then. And he said, and I quote, "Professional judgment is the judgment of the profession, not of the professional." Just think about that for a minute. Professional judgment is the judgment of the profession, not of the professional. And I really think the same thing is true with ethics. The moral compass of our profession serves as these guardrails for all public health professionals. These guardrails help align us with our profession's ethical expectations, even when we think what we are doing is what is best. So we have to really be able to think about what the difference is between what I think is best for me and what I think is best for the public's health. And part of this comes from the fact that in public health, we are making decisions not always for ourselves, certainly not solely for ourselves, but we are making decisions to make policy and other intervention activities for people other than us, for a community. So for an example of the danger of relying on our own personal moral compass, relying on what we as individuals think is right, one need only think for a moment about Dr. John Cutler. Dr. Cutler was the US Public Health Service physician whose mid-20th century syphilis research in both the American South as well as in the Central American country of Guatemala was determined to be unethical, both by current standards, that is what we believe now, as well as the standards that were in place at the time that this research was going on. After 20 years, over 20 years after his research stopped, Dr. Cutler continued to defend his work as necessary for advancing science. He was conducting experiments at a time when people and the healthcare providers had very racist views about health and about sexually transmitted infections in specifically. His work was based on his belief and others' beliefs that somehow syphilis had a different course of disease in Black Americans than it did in white Americans. So it was his scientific contention that he needed to find this out and figure out what was going on. He thought, even 20 years after the experiments were stopped, he thought he was doing what was best for public health science. He valued scientific discovery above everything else. He was following his own moral compass, but it turns out he was wrong. And so the question is, would an explicit set of ethical guardrails like we have today have helped him separate his own moral views with what his profession thought was ethically acceptable? And we cannot know that. Our public health guardrails were not clearly articulated in the early 20th century when he was doing his work. But today, in American public health, we certainly have these, and probably in all contemporary public health systems. In 2019, the American Public Health Association adopted a new public health code of ethics. This followed a 4-year profession-wide deliberation. And the ethics section of the association convened a multidisciplinary task force we engaged stakeholders to get input, to draft a document, and then to engage folks across the public health community. We included public health professionals who worked in local health departments all the way up to national agencies. We included public health laboratorians, social scientists, epidemiologists, engineers, and many other disciplines that practice in public health. And this code of ethics collected and analyzed what we thought were the primary values that drive our moral compass in public health. And we came up with 6 core values of our profession, and then 8 considerations for helping people actually make ethical decisions on the ground at the site where we do public health. And it provides a framework of how to incorporate ethics into our toughest decisions. So the 6 core values, these are not supposed to be ordered in, in order of importance, but we have to list them somehow. So I'll just start with professionalism and trust. And we know that this is a critical value because trust is the currency of public health. The effectiveness of our policies and practices really depend on the public trusting us to do the right thing. We gain that trust through decisions that are based on the highest ethical, scientific, and professional standards. Health and safety is another value, of course, because health and safety are essential conditions for human flourishing, and that's what public health cares about, is human flourishing. And because in most countries, governmental public health system is legally obligated to protect health and safety of its residents, clearly health and safety matters to what we do. Health, justice, and equity. This is obviously a value because human flourishing requires social conditions that provide equal access and equal opportunities for health for individuals as well as communities. Interdependence and solidarity, because the health of every individual is linked to the health of every other individual and to all living creatures, and to the integrity of our environmental ecosystems. We know now that over 75% of infectious diseases that affect humans started in animals. So we jumped to humans. So we have to be very clear about the fact that we are all related. Human rights and civil liberties, because we know that self-determination, privacy, and the absence of domination in its many personal and institutional forms, all of these are essential for human and community flourishing. And finally, inclusivity and engagement, because informed public health decision-making that engages affected individuals and communities really will be what we need to protect and promote flourishing of individuals, communities, and ecosystems. So this code of ethics, these 6 core values, really represent our field's moral compass. It's our message to each other, as well as our message to the people we serve, that we have a promise to them for what they can expect from us. We know what we expect from each other. We can hold each other accountable, and we know for the people we serve that they can then understand what it is we expect, they can expect from us. Now, the idea of infusing our values into all aspects of our work demonstrates our commitment in the field of public health to a more fulsome consideration of all aspects of public health action and decision making. That these 6 values really are the core, the foundation of what we do. And looking at our practice in public health through an ethical lens shows the public, our communities, that we're willing and able to deal with the hard stuff, that we understand that much of what we do in public health and as public health professionals is related to things that our communities value, that we must consider all of these values, a full range of them, and include that as input into our decision making. So for whatever public health action we take, we've got to consider a number of things. As I mentioned, we all know we in public health, we're a field of action. And so we have to think about what is going to be what are the inputs? How do we decide what action to take? Well, we clearly need to consider data and evidence. We are an evidence-informed field. We used to say we are evidence-based, and in fact, we do base most of our, much of our decision-making on evidence, but that's not the only thing on which we need to base our decisions. We do use factually justifiable evidence, to be sure. Sometimes that's we don't have much of it, so we have to think carefully about what next to do, because facts aren't always alone what we should consider. There are plenty of things that we can do that we really need to consider carefully whether we should do. So of course, public health law plays a role. It tells us what, as public health professionals, what we're required to do, and also conversely what we're not permitted to do. So we have to consider that as a constraint to our decision. To decide the should part, we have to recognize that people and communities have values, and we've got to consider these values carefully. It's especially important for us to pay attention when values conflict. Liberty versus health and safety, for example. And health is one of the most important things that we as humans care about, which means that decisions about what to do or not to do are almost always based in our deeply held values, which are based on our lived experience and the cultural context in which we exist. So knowing affected communities well and getting input about lived experience are critically important in terms of influencing what our action is going to be. Public health decisions cannot ignore the massive racial, social, and economic inequalities that are ingrained and often continue to be perpetuated by our social systems. So the question is, we come to a decision, we've considered all these things, how do we know if what we're doing is ethical? Using a deliberative and inclusive process, public health personnel can ensure that public health authority is not used in ways that are arbitrary or discriminatory, rather, or abusive of public trust. Rather, they can make decisions that build those things. So attention to the following considerations really can help public health professionals think about whether their decision has gone through the appropriate ethical scrutiny. One of the things we think about is permissibility. Would this action be ethically wrong, even if it had a good outcome? We have to think about that. Is this a permissible action? We have to think about respect. Would the action be demeaning or disrespectful to communities, even if it happened to be beneficial to health? We have to think about things like reciprocity. Have we done everything reasonable to minimize potential harms and offset losses that an action might impose on communities? To think a little bit about effectiveness. This is where our data come in. Will what we're doing work? Do we have evidence to indicate that the action will achieve its goal? Responsible use of scarce resources. At least in the US, public health is very poor. We are not well funded. We have to do a lot of work with very little resources. So often what we think about is would this action that we're about to implement demonstrate that we are, demonstrating good stewardship of limited resources. Proportionality is another thing we think about. Would the proposed action demonstrate that public health practitioners are using their power and authority judiciously and with humility? Are we making sure that the action is proportional to the need? Accountability and transparency, we'll talk a lot more about that during the next couple of days with communication, but would what we're proposing withstand close ethical scrutiny and be justified, can be justified by valid reasons that the public will understand? We might understand it perfectly fine, but we have to make sure our communities understand it well. And that leads to this final consideration, which is really public participation. This decision is mostly for our public. We're going to require them to do or not to do something. We have to ensure that the decision has included all affected stakeholders. The process of just identifying who those are can be very challenging, but it's critically important. And then, of course, is there ethical justification for any exclusion of a particular individual or community? We have to ask that question as well. So how do we do all this in public health? It's a lot. We're already struggling with, all the things we have to do. How do we incorporate this kind of thinking into our work? Well, I think the key here is really incorporate this kind of thinking into our work. From my perspective, all public health professionals need really 4 skills in order to make ethical decisions. We've got to be able to identify what the ethical dimensions are of a situation. We've got to be able to put words to what the ethical dimensions are, and that's especially important when we know that 2 values conflict, 2 or more values conflict. We've got to be able to deliberate a path forward. What does that mean? That means we have to get to a place where we have that public health action decided on by including facts, values, lived experience, and public health law as well. And then, as any good public health practitioner would do, we implement and evaluate. And we say, did this work as we expected? Were there any consequences we didn't expect? And we need to reevaluate and think about things differently, etc. So those 4 skill sets, I think, will give us all a huge leg up on incorporating ethics into our daily work. We think about this method as something that's reflective and participatory, multidimensional. We have to think about this as a process that is open to revision when we get new information. And certainly during COVID, this happened, daily, as Ashley was saying, every day we get new information. We didn't know what was going on. So we have to keep our methods for decision making open to this new information. Now, that new information might be data, but it could also be new information about a community's lived experience, or the values that communities are expressing. So we have to keep our ears open for all of those skills. And they will then help us continue to incorporate this in the way we do our work, as opposed to it being an add-on at the end. And I do think that each of us as a public health professional needs to know that it's our responsibility as a professional to understand not just the evidence that drives our work, but also understand and attend to the values of our communities and our profession in every aspect of our daily work. So as you all return this week to serve your communities, I hope you'll think a little bit about how you might begin to identify and address some of these important ethical dimensions of your work. I do want to echo Ashley's words and thank you for all the work that you all do to promote and protect the health of your communities. We all know it's hard work, and we're grateful for all that you do. I'm going to stop sharing now, and I would really like to begin our discussion. So I'm going to ask, if you do have a question, please enter it into the Q&A. And or if you'd rather just raise your hand and ask your question or give me your comment, I'd be very interested in discussing that. Just go ahead and do that, and then Patrick will unmute you. So thank you all so much. I look forward to chatting.
Thank you, Lisa, for highly informative, invigorating, and presentation. And I'm sure there'll be somebody. I mean, the issue that we spoke about before is that for a lot of people, ethics is something that you do when you do an ethics application, and once you've got that, then park it and move away. And I'm sure that you've found that in applying for grants and so on. What you presented is actually the wider dimension, the whole ethics of public health practice, which again is something that Ashley mentioned. And I think that's a challenge for us all to think about the ethics of the work we do as public health practitioners rather than as a particular researcher or policy person or somebody else. Is that, I mean, is that how you actually are encouraging us to think of the wider public health rather than as being a researcher, a policy person or something?
Yeah, I mean, I think they're all connected, right? So many public health professionals do research and they think about research ethics. They think about ensuring that they get informed consent from their participants and that they use the data wisely and they protect the data according to the requirements and they, analyze the data honestly and with integrity. These kinds of things are critically important for public health. That's really an important part of the data decision, the data part of the decisions we make. But our ethical obligation as public health professionals goes beyond that. And the reason it goes beyond that is because we are doing work on behalf of someone else. We're public servants. We do work to, improve the flourishing of communities. And we're not often, or sometimes we're not part of those communities. And so part of what we have to do is think carefully about the fact that we are being, asked to create policies and interventions that will affect people other than us. And we have to think carefully about that. It's especially critical when we talk about data collection and public health intelligence, right? Public health needs information in order to do the right thing. And that doesn't mean that we are entitled to any information we want at any time from any person. What we have to think about is what are those ethical dimensions of collecting data, of holding data, of having information about people that they might not either consent to or want us to have. That's a huge responsibility. And so making sure that we take that responsibility through a lens of, oh, I see I'm obligated. I have a responsibility here. I have, I have to do the right thing. And how do I know what that is? Well, that's how we think through things ethically.
Thank you. Are there any questions in the chat or anything that people would like to ask Lisa about the topic that she's talked about, ethics? Chris.
All right, Chris.
Right, sorry about that. Which Chris?
Oh, I'm sorry, Chris Kelly, who raised his hand.
Right, thank you for that. That was a really interesting talk. I wondered if you could maybe expand on the ethical implications of not making a decision.
Excellent question. So often what when I said we were a field of action, I think the assumption is that action is better than inaction. Most times we certainly feel like that's the case. But there is always, not acting or not, for example, collecting some information or having the right information has a moral valence as well. And we do have to consider that. Often when we talk to communities in particular about public health surveillance and collecting information about people without their individual consent, one of the driving ways to talk with people about their being able to see the value of that is to say, if we don't have the information, we are unable to make decisions about how to allocate funds, how to implement programs, how to help this community's health. And so talking about we really in ethics are weighing pros and cons of things. And there's definitely that weighing that has to occur with not intervening. So absolutely right. That's a huge part of what we're thinking about.
Lisa, there's Chris asking the question because he's across the ditch. He's actually in England and you're in the US and you're actually talking through New Zealand. So it just shows you the power of communication. Thanks. Tim.
Kia ora. Thanks, Lisa. My question might be a bit weird, but I'll give it a go. Obviously, people in the public arena define ethics differently.
Mm-hmm.
And I was wanting to know how you can influence and maybe better inform those people that might be on the fringes of society that have a very secure definition and thinking of ethics. Do you have any sort of recommendations on that?
Yeah, that's such an interesting question, Tim. And, in the US, we are extremely polarized and, more and more every day. And so we've got this very, fringe kind of idea going on. But one of the things that's really important when we think about ethics is ethics really is a collection of things we value. And so when I think about people who are like way on one end of the spectrum about something, what they're doing is valuing something very different than I'm valuing or that someone else is valuing. It doesn't mean that they have a skewed version of anything. It just means that what they value is very different than what I value. What I have found over many, many years and dealing with many contentious issues in public health and health in general is that ultimately, if people are willing to participate in public reason giving. So for example, here are my set of values. Let me tell you why I believe that. And other people say, here are my values. Let me tell you why I believe that. It's extremely rare that people can't find something that they value in common. And so I think about with public health, because we have to deal with such diversity with respect to what communities value, we really, as we go through and talk with people and get their feedback about what they're valuing and how what we're doing helps them flourish, we have to aim for what's common. What are we valuing that's the same? And I think sometimes that's a very tenuous thread, but if we can get that, that's a big place to start. Most people care a lot about being healthy, and most people care a lot about living their best life. The catch is that what living my best life is different than everybody else, what they're living their best life is. And what we have to do in public health, because we serve the public, we serve everyone. And we have to think about ways to help people, not just we think about our values, but help our communities think about what they're valuing and what how they value what they're valuing helps or hurts themselves, helps or hurts their communities, these kinds of things. So I think there is a lot of work to be done with the variety of values we have in the world. But I think we can almost always find that at least one connection, and to really build our public health programs, at least moving people along based on those commonalities is the way to go. Not to say it's easy, but usually you can find something like that.
Thank you, Liz. Angela.
Kia ora, thank you so much. I really enjoyed that. I wanted to just ask about your take on the Tuskegee syphilis study, because I take your point, that the leader of that study was following their own personal moral values and personal moral compass. But my take had historically been that actually, the public health service as a profession was partly responsible for that study. I mean, it went on for 30 years, it was published, whole range of people were involved. And I take your point that there was dispute, there wasn't necessarily consensus about what the ethical standards were. But I just, either maybe I misunderstood you characterizing that as sort of primarily about an individual and an individual's moral compass, because I had always interpreted that more as a progression in terms of a discussion about public health ethics and values in the US from a professional perspective.
Sure. Yeah. Great point and a really good question. So he was not alone. He certainly was not the only person who had these views and thought that this was a good idea. There were a panel of his colleagues, very high ranking in the government and the public health service, high ranking folks from various universities across the US that, reviewed his study and agreed to continue to fund it. And I mean, this was a common view of that group. However, well, let me just say that so it was a common view of that group. We didn't have at that time in the US a kind of sense of what our values as a profession was. In part, yes, Nuremberg trials happened and the code came down and all that, but Americans were very sure that didn't apply to them because they weren't, Nazis, and they wouldn't do anything bad to anyone. So it was the hubris really got in the way, I think, of our public health system. When we were able to kind of uncover exactly what was happening with the Tuskegee experiment specifically, or the Tuskegee study specifically, we did see that there were some people who didn't think this was the right thing to do, who were questioning this, who were concerned, but they didn't have that kind of background or public health professional moral compass to rely on. It was just much more of an individual versus an individual. And this particular individual had a whole bunch of other individuals around him that thought that this was an okay thing to do. Now, I will say, interestingly, when he at the same time did his experiments in Guatemala, there was we did a huge investigation of that at the Presidential Bioethics Commission, did a huge investigation of those studies, and there was a lot less support for that kind of thing. People were very worried that we weren't doing the right thing. They were very worried that we couldn't say too much about what was happening in Guatemala because we didn't want people to see what we were doing. And in fact, you know, there was a very short set of, you know, a couple sentences in the New York Times from an investigator that said, you know, it would be really interesting to do these studies, but they're ethically impossible to do in the United States. So what did they do? They moved them to Guatemala. So, you know, the idea that somebody knew something. And so I agree with you, it wasn't just John Cutler, but it was the people around him. And there wasn't that kind of safety net for me to say as a public, I think this is not right. And here's what I'm basing that on. I was just individual to individual. So now that we recognize that we need a moral compass for our profession, that will help public health professionals who might have questions about somebody, you know, being rogue or going off to do something that isn't right, they have that to kind of fall back on and support what their concerns are. So point well taken.
Thanks, Lisa. There's a question, three questions actually in the chat. One is, I wonder, ethics should be culturally sensitive, and would it be dependent on the different community we are working with?
Mm-hmm. So that's interesting. So, you know, we talk, and when I teach ethics, we talk a lot about, you know, what we value has a lot to do with our cultural situation, our cultural context. And that in fact is true. If we all think about, like, what do we value? We think, you know, a lot of us think about our grandparents or how we were raised, or, you know, various ways we get values and infused into our being. And much of that is culture. That said, I think we are able to think, we're able to separate things that are, you know, the ethical questions versus the cultural context or the cultural questions. And part of that is the motivation for having a moral compass for our profession, part of the reason to have one of these codes of ethics. So we as a profession say it's really important for us to, you know, honor autonomy, and but at the same time ensure that we recognize that, you know, community good matters. If a culture decides that they, you know, individual autonomy is not what we're into, it doesn't matter, it's not that great. So what's the rub for public health there? Well, then public health has to be culturally sensitive, clearly, because we are trying to you know, improve health of communities. Sometimes we have to be able to say, you know, what are we going to do here, because we are really valuing something like autonomy and this particular culture isn't. So there is this idea of being culturally competent, understanding what cultures want, and being able to square that with what our ethics are as a profession. And, you know, it's not always easy. It's easier than I think we often think, because we can get to a place where we, again, understand what the cultural context is, and separate what are the cultural things versus what are the values, and what are the actual ethical pieces of our professional moral compass. It's not always easy, and we have to be culturally sensitive to be sure. Most times we have public health, not most times, sometimes we have public health professionals who are from particular cultures and who can help us understand how that cultural context and how the public health moral compass can you know, work together or be beneficial to each other versus in opposition. But it can be challenging for sure.
Okay, another question. You talked about professional judgment as the judgment of professions, not the professional. I can think of several examples where the profession got it wrong and individuals who protested were demonized. And the classic one that's cited is Semmelweis, whose evidence based on the need to wash hands and seams. How do you think we can better address this sort of example, and if there are any current examples?
It's a great question. And, every time I say that quote, I do think about these, the exceptions to this are ABC. So I agree that there are always exceptions. I think one of the things that really is important when we talk about a profession is a collection of professionals, but it's also a community that's bigger than just professionals, the individual professionals. So the synergy that happens, I think, is critically important. And each profession has a responsibility to say, what do we expect from each other, and what can the world expect from us? And that is simply what a public health, or what a professional code of ethics is. It's really what do we value, what do we expect from each other, and what can the world expect from us? That should continue to be an iterative process. We should have professionals who say, I think we got this wrong. I don't think we should do this or that or the other thing. And that iterative process, that open to new information, that idea of deliberating through what our profession's moral compass is going to look like is critically important. And that happens in the context of the cultures in which we live. So, there were plenty of people back in Cutler's day who thought that everything was fine and we were doing the right thing and it was okay. And we've moved as a profession to be pretty clear that that's not okay. It's not all right to withhold treatment from people, or to intentionally, as he did in Tuskegee, or to intentionally infect people as he did in Guatemala, that's not something that we value in most contexts. Now, there might be some situations where, you do challenge trials, for example, where you're trying a new vaccine and you want to see if somebody, if the vaccine works, you challenge them with the disease. There are certain ways in which that is ethically okay, but it's context dependent. And that's why public health decisions, that decision to act, is context dependent. You have to have the facts, you have to have the values, you have to have the laws and the lived experience. And that not only is going to be different pretty much with almost every decision we make, with every action we have to take, but also could change over time, which we saw certainly with COVID, and we saw certainly with Tuskegee, and the arc of which, got us to this point where we actually are outlining specifically for people, if you're a public health professional, this is what we expect from you, and this is what the public expects from you.
So I guess that one of the questions that comes from that is, do you think Semmelweis, how do you think if Semmelweis would be judged these days?
Well, I try very hard not to do the asynchronous ethical judgment. I think, I think it's
We're in New Zealand.
Yeah, I think it's a challenge to. And certainly when we were looking at the activities of Cutler in Guatemala, it was hugely challenging to look back and say, what should this person have known, and what did they do or didn't do, what they do that they shouldn't have. And we can certainly worry about that. I think we have plenty on our plate right now to worry about what we're doing right at this moment. So I'm going to opt out of answering that question, Barry.
Well, David's got a question. Can you comment on whether Indigenous data sovereignty features in public health ethics in the US?
Great question. And the short answer is yes. In fact, we have had a couple of pretty, these are more research ethics issues, but we've had a couple of pretty well-known cases of Indigenous people's data being used in ways that they did not agree to, and that actually ended up bringing some pretty substantial community harms to them. In particular, again, a research effort, but the Havasupai tribe that is, that lives and has lived for its entire existence at the base of the Grand Canyon in the US. Some researchers took samples doing diabetes research, analyzed those samples, in agreement with the tribal leadership, et cetera, did their research. They retained those samples, and then on their own, the researchers did subsequent studies, some that had to do with schizophrenia and some that had to do with just looking at genetic and heritage and DNA and connections with folks. So they published some findings that were extremely offensive to the community of that tribe, and that tribe ended up suing the university and won. And a lot of things have changed with respect to how we should treat data that we collect from any person and any unit and any official governmental entity. So, or people, for example, for any people. So we do have now, some universities certainly have different rules about how to engage with Indigenous tribe, with Indigenous peoples, how and who will manage and keep and store and use the data in the future. To whom those data belong is determined before they are collected. So for example, in the US, we have both tribal public health organizations as well as state public health organizations, territorial health organizations, and those tribal organizations are just like any other. They collect and maintain their own data and have jurisdiction over how that happens. So critically important question, and we have not been the best at doing that well, but we are certainly getting better at doing that.
Thank you, Lisa. Are there any more questions? There's no more in the chat. And nobody's got their hand up.
Could I contribute one, Barry?
Yes, Chris.
Lisa, ethics is a fascinating subject for me as well as for you. And I noticed that you were talking about a professional code of ethics for the field of public health. Mm-hmm. One of my disciplines is public relations, and I belong to or work with professional bodies in that field, all of which have codes of ethics. But the reality is that those are purely advisory because there are no sanctions associated with them. And in another field that I operate in, of crisis communication, the evidence seems to be that in crisis management, ethics or ethical principles are distinctly secondary to dealing with the immediate issue at hand, and even considered not relevant. So I wondered if you could talk about not only the desirability of code of ethics, with which I completely agree, but what might be some of the limits of a professional code of ethics.
Excellent question. So one of the things that I have found very interesting as we started this process in 2019 at the American Public Health Association was, of course, we did our homework and we looked around at other professional codes of ethics. And as we did that, it became clear pretty quickly that most professions have what they call a code of ethics, but really what it is a code of conduct. You must do this, you can't do that. You have to do that, you can't take gifts, et cetera, et cetera. We're all familiar with those, don't lie, cheat, or steal. So those kinds of things. But what we wanted to do for public health was to help a public health practitioner recognize and understand what they're getting into if they want to be a public health professional. If you want to be a public health professional, we want you to understand that this is the moral foundation of our profession. So that's one piece of it. The second piece of it that we really were primarily interested in was how to help public health professionals think about ethics as they make their decisions in their day-to-day work. So our code of ethics is in fact an enumeration of our values. And then the rest of it is really, how do you decide what you're supposed to do if you're sitting there trying to decide what to do in a local public health department? So we added to that things like, what are the activities of public health, and what are the ethical things that might come up or that you should be thinking about from them. We also added a whole section on how do you make a decision, what decision-making models are available to you to think about how to bring in all those different inputs into your actions. How do you help communities identify what their values are? How do you discuss and deliberate to resolve ethical conflicts, or to find compromise, those one or two things everybody has in common that we can compromise about. So it is much more of a guide. Our code of ethics is really much more of a guide to, here's our ethical foundation. Here is how you decide with your communities whether what you're planning to do meets ethical expectations. And here's a decision-making model or two or three that you can use to get there. So it does not have in it, and we actually heard this, we don't have like, don't take gifts, or, you know, don't do this, or don't do what benefits you, or, you know, you should disclose conflicts of interest, these kinds of things. It's not that. It is really a tool to help public health professionals understand what our moral foundations is, and that they have an obligation and a professional, you know, a professional expectation that they will address the issues associated with the ethical issues associated with all the decisions that they're making on behalf of other people, on behalf of their public every day. So it's a little bit different. Now, this is part of the reason ours doesn't have teeth, right? I mean, you know, we can't punish someone for, you know, not having the same value, for example. It's just not, it's not a code of conduct, so it doesn't have teeth. But what we have discovered is that our 4-year-long, you know, public health wide, profession wide deliberation about this really ended up with, I mean, not 100%, but certainly the lion's share of public health professionals have bought into this idea. They've expressed buy-in that they believe that this is important for all of us to know how to do, and they, you know, while people will end up with different decisions possibly about the same topic, depending on the community they're serving and depending upon their own jurisdiction, et cetera, they have all agreed that this process of making transparent, ethical, deliberative decisions is really important. So we don't have the same kind of teeth like the American Medical Association has teeth. If you are a physician, for example, in the US, and you violate the code of ethics, you know, the medical board can take your license away. That's just not the case with the kind of code of ethics that we have.
Thank you.
Thank you for that helpful answer.
Angela.
Well, Chris's question just made me think about an answer that Lisa had given earlier, that, you know, in relation to cultural specificities, we might have the same set of values, but in different cultural contexts, we might weigh those in different ways. I mean, I wonder if what Chris is saying, that in an emergency or a crisis, we just weigh those values in a different way. So actually what we prioritize is saving the most lives. That's not necessarily throwing out ethics, it's just a different prioritization. And certainly, you know, ethicists in the UK and in America argued it was some Australian Savlescu said, you know, when we're distributing COVID vaccines in a pandemic, everyone's a utilitarian, right? Like what everyone wants to do is just maximize, you know, community health outcomes. Now, New Zealand was a bit different in that respect, in that, you know, even in the peak of the pandemic, we were still talking about equity in relation to distributing vaccines. But I wondered if you would consider those comparable kind of examples, that cultural specificity and the emergency context.
I think so. And I also think that, you know, we talk about ethics as a process that considers everything. And so all things considered, what is the best thing to do here? And when you're in the middle of a crisis, particularly with, you know, a fatal illness that we don't know what's causing it or what's going on, or we, you know, there's so much uncertainty. I mean, we kick into different gear, right? Precautionary principle becomes one of the most important things we think about. You know, now we're thinking about things differently with COVID. So time can change that context. Different communities can change that context. You know, different types of problems or decisions that need to be made can change up that context. So I absolutely agree that, you know, so how we weigh things is different in an emergency situation. That said, I do think that there are, one of the reasons we have moral distress among public health workers, especially those like emergency responders in public health, is, you know, they're asked to make really quick decisions that are, you know, that there's so much uncertainty that they start to feel moral distress. Like, I don't know if I'm doing the right thing. I don't know what the right thing is to do. I'm not sure how to do this. I'm just going to, you know, act because action is better than non-action. Not always the case, but let's say, you know, as a response, that's what you're trying to do. I do think it behooves all of us to understand that even if we don't say it out loud, or even if we're not, you know, consciously aware of how we're weighing the different features, the different moral valences of our options, we're doing that. Some of us do it much more, you know, transparently or much more consciously than others. But what we want is public health professionals to be thinking about the various moral considerations that the profession holds to be important, not just, or perhaps instead of, what they personally are thinking Because when we ask public health professionals, what do you worry about? What are the ethical dilemmas you have? There's no shortage. We get a long list of things that people are worried about ethically. When we ask them, how do you decide what to do? They say, well, I do what I think is best. I do what I would want to have done to me. You know, and these are perfectly fine answers if you're deciding for yourself, but they're not the right answers for when we're deciding for the rest of the public. And that's why we really want the public health profession to understand that this isn't about what your grandma always taught you or what your elders in your community think is the right thing to do. This is about what our profession is supposed to be doing. And so I think it all ties together, but great point. The weighing of things is different depending on context, to be sure.
Thanks, Lisa. We do have another question, but we've run out of time for this, but we can perhaps come back. You can come back to that and the Q&A. It's in the Q&A. And you can actually type the answer on that. But once again, on behalf of PHONZ and all the participants, thank you very much and great presentation. Thoroughly enjoyed it. And you raised some really important and challenging issues. And so thank you once again.
My pleasure. Thank you so much for having me. Take care.
Thank you. Good. Well, it's thank you, and I think that's following on from Ashley, a wonderful presentation from Lisa, and really has challenged us all as public health professionals. It's now my great pleasure to invite Dr. Chris Galloway from Massey to give a presentation on something that we're all being confronted with, and probably very few know what it is. Chris, as he mentioned in the question and answer, he's a public relations and crisis communication, but he's developed a strong interest and involvement in AI. This presentation is about AI and public health, changing the conversation. So I hope that doesn't mean that in future, Chris, PHONZ conference will be AI generated and we won't have to be here. So over to you, Chris. Thank you very much.
Thank you, Barry. And in response to your comment, you never know. The AI is developing new capabilities all the time. I'll share my screen in a moment, but one of the things that Tim, I think it was, raised in the previous discussion was simply the fact that different people have different views on things. And I'm going to be talking about how we can work as public health people to build a consensus around the applicability, the utility, the value of AI to what we do. And I was also fascinated to hear what Lisa had to say about ethics. One of the huge issues arising with AI is just simply ethics. I have an 800-page handbook on ethics of AI sitting on my bookshelf. Have I read all 800 pages? I'd have to say that would be an aspirational goal, but we're talking about stuff that is very much on point for now. So I'm going to share my screen. And I hope everyone can see this now. Are you seeing my screen?
Yes.
Good. Okay. One of the reasons why explainable AI is important is that we as human beings find it difficult to live with uncertainty. And of course, in the last few years, we have had to deal with acute uncertainty to do with things like COVID and other health and natural disaster related emergencies. So we like to be able to attribute causes, we like to be able to understand what's going on. Not always the case, as we will discuss, when it comes to AI. So here's a definition of explainable AI. And by the way, the New Zealand AI Forum has a working group that I'm part of that is putting together a white paper on explainable AI, an illustration of how important people deeply immersed in the evolving AI industry consider it to be. So you'll see the comment there, not all AI is explainable. There are so-called black box systems where sometimes even the developers don't understand completely how the system produces what it produces. But explainable AI, you'll see in the red type there, is where a typical, i.e. a lay person, can understand the logic and decision-making process. And the goal typically, I would suggest, should be to be working with explainable AI systems for reasons I'll unpack in a minute. So we need explainable AI to build trust and adoption. We'll come back to the point of trust, but people who don't trust something self-evidently won't engage with it, won't use it, won't advocate for it, won't be happy if AI is part of a public health solution. And certainly public health would qualify as a high stakes domain as far as I'm concerned. There are some other terms that get bandied around, so just to help be clear on terminology, there is interpretable AI. Some people use explainable and interpretable in more or less equivalent ways. That's where you're able to explain how the system works internally, how it makes decisions, and to do that in a way understandable to a human user. And transparent AI is where you have the ability to produce independent verification and accountability. And accountability, of course, is something that comes very much into the whole area of ethics that Lisa was talking about in the public health context. You'll notice the reference there to external auditing and evaluation. There is a strong move around the world to attempt to regulate AI. China has, in the last few days really, had a first go at doing that. Regulation is being considered in the US, UK, and elsewhere. But if we want to persuade people, I thought you might find this interesting, to develop a level of comfort with the involvement of AI-enabled systems in public health. How do we understand that process? So I want to chat about this diagram, and it comes from the work of a psychologist called Robert Cialdini. It talks about two routes to persuasion, the central route and the peripheral route. If you have an audience that is motivated, they want to understand, they can see direct personal relevance to them and to their interests and what you want to talk about, then you can use logical argumentation because people are willing to put in the effort to understand the logic of what you are talking about. They will evaluate the message that you give them and invest time and energy in doing so. That tends to result in a lasting change of attitude that you see there. The so-called peripheral route is where people don't see a whole lot of direct personal relevance. They might have a passing interest, but they're not prepared to invest brain processing power in understanding. They will be persuaded by cues. Some of those cues can be things like expert spokespeople, celebrity spokespeople, those sorts of things. Sex appeal is actually another cue that helps persuade people, but that only leads to a temporary change in attitude. So my point here is that if we want to, over time, persuade lay publics that the involvement of an AI system in public health activities is a good thing. We need to understand where our audience is at in relation to their understanding of and willing to accept an AI element in the public health processes to which they're exposed. And here's my suggestion here is that if practitioners, as in public health practitioners, don't explain what's going on, who will? And I'm suggesting that in some contexts, at least, commercial operators might step into the gap if public health authorities are holding back. Here's just one example from the US of an AI system developed by an outfit called Healthily that allows people to check their symptoms using their phone or their computer, and as you see there, to engage with quote unquote medically verified content. Now, we may have questions about what kind of content comes back to people, but it's using AI to check what people are telling the system about their health issues. A key point, I believe, is that it goes also to what Tim was raising in his question in the last session, is that individual requirements for explainability will vary. Someone may want the intimate detail if it's available. Another patient will refuse to accept a decision made by an AI system that they cannot understand. So, as in all contexts, we need to learn as much as possible about our audience. And I'll just make the point as we go on that this is increasingly important, I believe, in the Aotearoa New Zealand public health context as it is elsewhere. I have connections with an AI startup out of a university. Their technology uses what they call a suite of AI engines. And they have recognized the need to explain to those who are using or end users of the technology what's going on, what the process is, what the benefits are. So the question is for us, who are we trying to explain to? Are we trying to explain what's happening to a lay audience, in which case certain things that we need to keep in mind, or are we dealing with a more informed audience, which is this? The key point, another key point, I think, is that explainability, as you see there, is inherently contextual. So I did my PhD many moons ago on risk and public relations, and what I learned in looking at that whole area was that there is virtually no correlation between the way that lay people and subject matter experts view risk. It is no different here. As you'll see in the text there, what's explainable to an AI expert will greatly differ comparing approaches by people in other contexts. So what could and should we do in the public health realm? I believe that as people who are looked to by lay audiences for expert and informed assessments, how we talk about AI actually does matter a great deal. I view the public discourse about AI as being on something of a pendulum. At the moment, we have organisations internationally promoting the idea of AI for good. Other people, by which they mean social good. We have other people saying it's hugely scary. Today, it's been reported that the Secretary General of the UN, in talking at the first Security Council briefing on AI, said that unrestrained AI could cause a great deal of quote unquote death and destruction. I think the pendulum there has swung too far. Now, when it comes to AI-enabled applications like the one from the startup I mentioned, we can end up focusing on a specific application and all the issues and benefits associated with that. But my suggestion or proposal to you is that as public health practitioners, it's a good idea, and I've said the same thing to public relations audiences, to get a good overview of what's happening and to get some of the terminology clear in our heads. So we need some language to describe what's going on and what's possible. I've suggested here that we need what I've called a dynamic center in our discourse. Dynamic because the technology is changing so very fast that we can't adopt fixed positions. What we can do is identify some key principles and articulate those, both in relation to benefits and risks. No different from a surgeon explaining to a patient that the operation they're about to undergo should have certain benefits. There are small risks potentially associated with it, and those, of course, need to be explained as well. It's true also in the AI area. Now, I suggest to you that it's about trust, to find there is a firm belief in the reliability, truth, or ability of someone or something. When in the literature around trust for individuals, it talks about a so-called circle of trust that we have as individuals, where there are certain people that we will rely on, we trust what they say, we have confidence in what they do. My suggestion there is that we work to put AI inside patients' so-called circle of trust. And we can do that partly because of what Lisa was talking about in the previous session in relation to practical ethics being worked out. And while that was the last slide, I want to assure you that AI did not make this presentation. No ChatGPT or equivalents were consulted in what I've just shown you. So at this point, I want to thank you for the opportunity to share with you. And I'm going to stop sharing so that hopefully we can have a bit of discussion. See if I can get out of that. Here we go.
Thank you, Chris. Has anybody got any questions for Chris? I think that either in the chat or through putting your hand up, the Q&A. Chris, we're talking, this is a session about ethics. What do you think of the ethics of applying AI to public health then? What's the ethical considerations?
The typical ethical considerations that people talk about in relation to AI have to do with, for example, bias. Because AI systems work on training data put together by human beings, almost inherently and inevitably, the humans' biases will be reproduced in that training data, and there are things you can do to mitigate the effects of that. But those biases may be everything from gender-related, sexual orientation-related, race-related, and so on, all of which could transfer into an AI system being used in a public health context. So that's one aspect of it. Another has to do with data privacy, that kind of thing. The question of data sovereignty came up in the previous session. That's also a highly relevant question, which from as far as I am aware, is very much an open question at the moment, and I'm thinking about that in our country as well. I see Angela has a
Question?
question. Look forward to it.
Thanks, Chris. I was wondering if you can comment on explainability in comparison to explainability for standard clinical decision making. And so I guess what I'm a little bit worried about is sort of some sort of AI exceptionalism, because on one level you say, okay, the surgeon can explain why they think this is the best course of treatment. But a lot of the research shows that there are gender, weight, race, systemic biases that pervade clinical reasoning. So while the surgeon can give you a story, it's not necessarily reflective of all of the inputs that are influencing that decision making. So maybe are we being a little bit overly cautious about explainability in relation to AI?
I think we could be. One of the things that has been driving my understanding of the need for explainability, and I thought I had a slide on this in there, but it didn't come up, is that the Pew Research Center in the US did a major study, which was published in February. And it showed that a majority of Americans, so of course, their attitudes may be different from those here, were not confident of about the use of AI in public health context. And in fact, if you that's based on putting together the people who weren't prepared to accept it, those who were basically the don't knows. But there was a majority who were not happy at the moment. An interesting finding in the study was that looking out ahead, like potentially 50 years, they could envisage that AI would be far more trustworthy. Now, my own position would be that explainability is needed at a popular level where the AI technology has been tested and shown to deliver real benefits in the same way that surgical interventions, which have perhaps been performed many, many times with real benefit, are able to be explained along with the risks. I mean, many of us may have had various procedures at different times where the doctor says, we're going to do this and that, the results will be this, we hope, and there's a maybe 5% risk factor in there. And because we have confidence in the medical professionals we're with, we're prepared to allow them to go ahead. So I guess I'm extrapolating from the surgical experience to say, with AI, although the developments in the field are so very rapid, and there is a need for a careful evaluative approach to the new developments, trust building through appropriate explainability is key. Hopefully that makes sense.
Thanks, Chris. There's a question in the Q&A. What do you think some ethical examples of using AI might be in public health, and what might be some dangerous, unethical applications of AI in public health?
I actually have a book called The Robot Will See You Now, which talks about clinical practice and AI and robots and that sort of thing. I think it comes back to trust. And again, I think that relates back to what Lisa was talking about before. I think because the technology gathers a lot of data, there are issues surrounding the use of that. And I do know that there is an increasing push to put some guardrails around all of that. It really depends. I've thought about, in a system where you have both human beings and AI systems involved, what is the locus, or where can you locate the ethical responsibility for the use of that system, and the best answer I've come across is that it lies with the designers of the algorithms in the first place. And that would apply to AI systems used in public health as in other domains. But that is still very much kind of, I can call it this wet concrete. Nothing is set. There are debates going on, and I'm sorry, this sounds like I'm not answering the question very well, but I think the examples depend on, or assessing the use cases depends on the intent of the developers. And this is why really we need some key principles put together as reference points for AI use. The UN Secretary General in his comments today was actually proposing that worldwide there be a body like the Intergovernmental Panel on Climate Change to have an overview of AI developments because of the potential for harm.
Thank you. Claire Slater has her hand up. There's one question, if we have time in the Q&A, which you could reply to. Claire's put her hand down now. Oh, never mind. Well, the question in the Q&A is, how much transparency should there be in the use of AI in a clinical context?
I think there should be as much. So I'll just keep going. I think there should be as much transparency as the technology allows. And what I mean by that answer is that I mentioned at the beginning that there are some so-called black box systems, AI systems, that produce output, but even the designers are not fully aware of how it actually does that, because it learns after the initial implementation. But that's what I mean by saying there should be as much transparency as possible, especially bearing in mind patients and people who are involved in public health projects.
Thank you. We have another person with their hand up. Roland, are you there?
Can you hear me?
Yes.
Yes.
Oh, hi. Yeah. I'm a little bit nervous. Sorry. Yes. AI. I know there's a lot of probably be a lot of cultural and a lot of ethnic answers about it, but I think when you put down people are scary, I don't think it's because they're scary. It's because of the unknown. If people don't know anything about a certain, like AI is quite new, but in some parts of America and the world, it's not new. Is that right?
Yes, that is correct.
Yes, and because in New Zealand here, it's just kind of new. I'll just tell you a little bit of a corridor. It's really quick. My son did an AI photo of my great-great-grandmother. We didn't have one. So what he had done was he had gotten her sisters, put them together and asked AI to come up with a Māori woman standing in the wind with her hair blowing and wearing clothing back from the 1900s. So AI came up with, you can have like 50 different pictures of it, but they came up with about 30 of them. So out of the 30, we picked one. But what I'm saying is about this, even in the art world, they're a little bit scratchy and iffy about it because it's that art they say. But what I'm talking about health is, yeah, it's not scary. It's just that it needs to, you're right, it needs to be explained a little bit more deep and a little bit more for people to understand.
I agree with you, and that's why I'm talking about explainability, because people have a right to make informed decisions in the public health sphere as well as elsewhere. And that's why I believe that explainability, you know, as much as we are able to achieve, is critically important. And so, to repeat a point I made earlier, I think it's important for public health practitioners to get an overview of what's going on, what the potential is, what the possible risks might be, but also, in my own opinion, to emphasize the benefits so that people can make informed decisions.
Yes, thank you. Thank you for that. The other thing too about health is that I was talking to my colleague. She's just sitting over here walking away now, and I was talking about it'll be beneficial to the health system because of its quick thinking. And I'm not saying that we as humans and as people can't think quick, but if you get a whole bunch of people around the table speaking about one solution and one problem, one solution, you could also, and you're talking about having a group that says either yes or no, it would come up with so many different, not scenarios, so many different answers to a problem. So it would be up to the people that were sitting in the meeting to say, okay, which one would be the better one? And is it ours or would it be the AI decision that we're going to pick?
It certainly can improve things by cutting back time. There is evidence from a recent study that people who are writers of various sorts, professional writers, improve their efficiency by about 40% through using ChatGPT. So there are definitely benefits. But ka pai, Fraulein?
Thank you so much. And yeah, my son's been looking at the AI now for 2 years. He's actually quite, he's actually quite intrigued by it. So am I, because I know that I came out with a bit of a plan about AI in the health system that I had put into a document, but I don't know whether it's going to be any good, but I believe AI is going to be part of the future now, and yeah.
I agree with you, and one of the things that I'm conscious of with the technology produced by the startup I mentioned earlier, their equipment is so portable that it could be put in a van and taken into rural areas here,
yes,
including Māori rural communities, to help address some of the inequities that the popular discussion refers to. So there I see a very real benefit. But Barry, I see you kind of checking times. How we going?
Oh, okay, sorry.
No, I'm very happy to talk to you.
No, thank you so much, and thank you too for answering the questions. No, I am really quite interested in AI myself.
Well, I would be happy to talk to you offline at a convenient time.
Okay, thank you so much.
Good. Well, thanks. Thank you, Chris, for that presentation and allaying some of the fears that we have and creating some others about the use of AI in public health, and explaining to us exactly what it does mean and perhaps the challenges, but also the advantages of AI in public health. So thank you once again.
Welcome.
It's now my pleasure to welcome and introduce Associate Professor Angela Ballantyne, who's from the University of Otago. Angela is the president of the past president of the International Association of Bioethics, and has been a regular visiting scholar at Yale University and at the National University of Singapore. And we're delighted that you're able to give us a presentation today, Angela, on consent, inclusion and trust in big data research, which actually follows very nicely on the AI. So thank you very much.
Yeah, thank you so much, and thanks for the invitation. I think actually what I'm going to say follows on really nicely from what we've heard previously. So let me find these slides. Have you got those? Can you see those?
Yes.
Great. Okay, thanks. All right, so inclusion, bias, consent, and big data. Essentially, the problem I'm interested in is an ethical trade-off, which is what Lisa was referring to in terms of you've got all these ethical values, but for me, the really interesting part is when those values are in tension and you've got to figure out what you're going to do, often out of two sets of, not perfect answers. So the bit that I'm interested in is, as we've heard from Chris, there's a concern about bias in AI and big data. If the data that you're using to train the AI is not representative, that AI model or program is not going to perform as well for some sections of the community if their data wasn't included in the training data. So there's a real focus on inclusion and diversity in relation to AI and genomic research more broadly. But at the same time, sometimes we run up against a trust barrier. So in high trust contexts and with high trust and with subgroups within a population who tend to have high trust in the health system or in government, often they are more comfortable with more flexible consent models. However, in a low trust setting or with communities who, for very good reasons, historically have been harmed by public health systems or by the government, they tend to have lower trust. Often there's a call for more consent, more individual control of the data in that context. So you often get this interesting and complicated tension between wanting to include data from marginalized groups to ensure that those groups can benefit from our big data analyses, our AI models, and our genomics research. But at the same time, in order to build trust, we might think we need a kind of more consent in that context. And that tension pulls us in different directions. So I'm going to start with something a bit fun to start with. This is a story that went viral on Reddit a few months ago. And I promise, going to refer to more academic sources as we get going. But we're going to start with the glory of Reddit. All right. So this was a series of AI-generated photos where someone had asked the AI to produce photos, historical photos, selfies of a range of different groups. So here, the few I've chosen to show you are samurai warriors, World War II soldiers, Indian Americans, and Polynesian people. Now, the first thing that kind of is really striking here is the ridiculous smiles on people's faces. And the reason this has happened is because the data set that the AI model is using is predominantly American photos of selfies. And what the model is doing is assuming something that's smiling, and that's kind of big, cheesy Duchenne smile, that's actually quite culturally specific. The AI model is assuming that is actually a ubiquitous feature of human nature and human interaction and facial expressions. Now, in fact, the way smiling operates in America is quite different to the way smiling operates in other cultural contexts. So, for example, countries that have what's called low levels of uncertainty avoidance, and Russia would be a good example here, tend to interpret smiling as a sign of lack of intelligence. Countries that have high levels of corruption tend to interpret smiling as dishonest. So the cultural meaning of smiling varies really specifically in different specific cultural and even time contexts. But that diverse cultural history and experience has been homogenized and kind of subsumed under the dominant cultural norm here, which is kind of the American smile. So we know that the AI has got this wrong. And I was thinking of showing you some photos, sort of more historically accurate photos of Indigenous Māori communities or Indian American communities. But I run up against a challenge there, which is, and rightly so, that concerns about digital data sovereignty, which refer to the rights of Indigenous people to control access to their cultural heritage and how those examples of cultural heritage are collected, accessed, and used, means that it's not straightforward for me to just take images that might be available in, archives or libraries in New Zealand and show them to you publicly without permission. For a range of reasons, some Indigenous groups object to showing images of people who are deceased. More broadly, photos of Indigenous communities are typically taken by colonizers, and so there's a power dynamic going on even in the kind of construction of those photos. So there is some data available that could help at least illustrate why this AI model's got it wrong, but it's not straightforward in terms of me accessing.
You're on mute.
Have I unmuted myself, did I?
Yes.
Sorry. So to say that again, is it more problematic to build AI models without representative data or to use data in low trust settings without consent? Now, the easy answer there is to get consent. The trouble with big data research is often it's really problematic to get consent, and getting consent can delay the research. And the more barriers that we put up to protect certain data sets often can divert researchers to other sources. So there's a number of private companies that work in health data analytics who say they would use clinical data from real world health systems, but getting access to that is so difficult in terms of all the regulatory controls. It's easier for them to use other sources of data, for example, credit card data, Google search terms, other data that is not as protected, but still gives information about health. So we've got to think about how we're kind of constructing the regulatory framework here. And so what I'm interested in, as I said, is these tensions between inclusion. So the more inclusive our data set is, the more diverse it is, the more we reduce bias. But sometimes getting more inclusion runs up against consent. In a high trust setting, that's not such a problem. In a low trust setting, it's difficult. So let me give you a sense of why we're worried about the representativeness of data. So this refers to data that's used for genomic research. The vast majority of that data that's at the moment driving, for example, precision medicine, big biobank data, comes from people of European descent. So a recent meta-analysis found that 82 to 95% of all genomes that have been collected and studied come from people of European ancestry. That's really distorted in relation to the genetic diversity that exists on the planet. One of the other challenges we come up to here in relation to genomic research, but also just health data research more generally, is complexity around concepts such as race, ethnicity, and genetic ancestry. So what we're interested in is the extent in relation to genomics, different allele frequencies and different genetic variation between different groups. And in relation to ethnicity, that might be different health outcomes as a result of different cultural behaviors. And so we are interested in that, but there's no easy, clear term for identifying that. And so, for example, we know that race is not a biological concept. It's a concept that was socially constructed in the 18th century, really to allow naturalists and philosophers to create a hierarchy of human beings based on geographic background and biological features. And despite the fact that we increasingly recognize that, race is still used as a proxy for genetic difference and variation in a lot of these studies. So we're interested in diversity, but it's a real challenge figuring out what kind of conceptual category we can use to frame that. And then when we're trying to obviously compare between different studies, it's problematic that terms like genetic ancestry, race, and ethnicity are used really inconsistently across studies. So we're also interested in bias in relation to big data more generally. So this is a model by David Leslie. I think it's a really great paper that illustrates the levels of bias that can creep in the entire kind of AI life cycle. The bit that I'm primarily interested in today is sampling bias and lack of representative data sets. And so some examples there that you probably have heard of. 2019, Obermeyer in the US showed that a really widely used predictive health algorithm was biased against Black patients. So was only referring about 18%, of the group of patients that was flagged as needing additional healthcare, about 18% were Black. Actually, that should have been about 46%. And the reason that that happened is because the developers had used healthcare expenditure as a proxy for health need. Now, that proxy worked reasonably well for white patients, did not work as well for Black patients because of historic distrust and lack of engagement with clinical services and bias in terms of referral. And this is kind of clinicians' bias in terms of referral onto tertiary services. Another example that was talked about in relation to COVID was the need to collect skin color data in relation to pulse oximetry meters. So that was necessary to allow for the AI to correct and offset skin tone in relation to oximetry readings to make sure they were accurate for Black as well as for white patients. More recently, a study published in 2020, looked at training data for a computer assisted decision-making tool in relation to x-rays. If you trained the x-ray, the computer assisted decision tool on x-rays from men, then the AI was much less accurate for female patients and vice versa. So the bottom line here is it really matters how much data you've got to train that model. I mean, a project I'm working on with colleagues in Singapore at the moment is looking at an AI model for diabetic retinopathy. Again, there, because the Malay community, who's a subgroup in Singapore, tends to use less preventative healthcare or possibly is excluded from preventative healthcare. There's less data that's been from that community that's been used to train the model, and so that accuracy in terms of prediction for that subgroup is less than the model overall. So that's why we worry about bias and why we worry about inclusion. And so we're left with this kind of dilemma. On the one hand, we want equitable access to the benefits of data research, but on the other hand, we've got concerns about consent and data sovereignty. So what are those concerns? The concern there is really in relation to health data, the types of limits that are on health data in relation to sharing that for research. Now, this concern about inclusion and lack of representativeness isn't specific to AI. It's actually something that's widely recognized in relation to evidence-based medicine more generally, right? The situation we ended up in, where we primarily used middle-aged white men as our research participants, and the implications that had for clinical research. So I'm just going to quickly run you through the debate about inclusion from a research ethics perspective, and then use that as an example to think about it from a public health perspective. So it's really useful, Lisa, talking about the Tuskegee study, the Nuremberg studies, as seminal examples of unethical research. On New Zealand, obviously, we have our own seminal example, which was referred to as the unfortunate experiment. It's also worth noting that the concern about exploitation in research and like actively using vulnerable groups for research purposes wasn't limited to these kind of very specific high profile studies. They weren't the exception. So, you might be aware or not that from sort of the 50s to the 70s, a lot of drug research was specifically done in prisons, because prisoners represented a captive population that were very useful for drug developers and pharmaceutical companies. So Holmesburg Prison in the US had 33 pharmaceutical companies operating there, running drug trials between 1952 and 1974. Then in relation to those studies, a number of countries, the US as well, had big national inquiries that looked into those practices, developed a set of code of conduct. So in New Zealand, we had the HDC Code of Rights come out of the Cartwright inquiry. And that led to a real protectionist phase, where for a period it was viewed that the ethical way to do research was to be really restrictive, focused predominantly on the least vulnerable group in the community. Now, what we came to realize after a while was that if we exclude children and women and pregnant women and ethnic minorities from research, we're building a body of medical knowledge that doesn't serve those communities. So now we've shifted more into a balance phase where increasingly there is efforts to responsibly include groups that might be deemed vulnerable or marginalized back into the research agenda. And kind of every iteration you see of research policy in New Zealand and overseas as well tends to be kind of more and more liberal about including those groups. So this tension about kind of inclusion and bias is well documented in the research base, sort of even before we get to big data and AI. But what's particularly tricky about big data and AI is the difficulty with getting consent. So you'll be aware that in New Zealand, if you want to use health data for research, you can apply to get a consent waiver from a research ethics committee. So the way we tend to manage inclusion and access to data is via a research ethics model. I'm going to argue in a minute that actually I think a public health ethics model is possibly more effective. This is a study that I and colleagues did with researchers and ethics committees in New Zealand a few years ago. And what we found was quite a different view from these two groups regarding consent waivers and the value of consent relative to equitable access to health benefits. So research ethics committees tended to be more concerned about consent. So one member said, you can't just say this is the public good because it's about diabetes and fat people in South Auckland, so we won't even bother getting consent. You know, the first thing is you have to get consent. We're not even interested in talking about public interest, public benefit until you've justified that getting consent would be impractical. But researchers, on the other hand, were really motivated by concern for health knowledge that would serve their communities. So you think of the potential benefit of, you know, women in this target group, and you weigh it up against any harm that you'd be doing. The women have already gone through the system, they've been treated, the health data is just sitting there, you know, we could use it. It was overwhelming, you know, in our view, we had a moral obligation to go ahead and do the study without individual consent. We did another study that found that actually for research ethics committees having to adjudicate on this, having to give consent waivers, and essentially what you're trying to do there is judge, you know, would the what would the community think? Would they think it's more important to go back and get individual consent from people to use their data, or would they prioritize the benefit that could come from using the data? And ethics committees found that really difficult. So people said, I think we have an enormous responsibility, and if we can sort of share that responsibility with the participant, or if they're happy with it, I'm happy, but here we carry all of that responsibility to kind of judge public interest ourselves. It leaves a bad taste in your mouth, caused my hairs to rise up on end, I feel uncomfortable, I'm definitely losing sleep. So consent waivers are a really tricky process for research ethics committees to have to make a judgment call on. And partly the reason for that is that we know that specific communities are more distrusting and would be less comfortable sharing their data. So in Norway, for example, a study in Norway a couple of years ago asked people leaving the hospital, what would your preference be for us using any clinical data or biological samples that were taken while you're in hospital? 90% of people in Norway said, I'd rather either know nothing, like tell me nothing about what's going on, just use it, or I prefer an opt-out system. So that's a very homogenous community, high trust community. Consent is not such a problem there. We see a different narrative for communities that have historically been harmed by health research and public health. So famously, Linda Torway-Smith argued in Decolonizing Methodologies, research is probably one of the dirtiest words in the Indigenous vocabulary. We know from research overseas that racialized populations, sort of minority populations, typically have higher levels of institutional distrust in governments and health authorities and are much more reluctant to have widespread access to their health data. Another study in relation to genomic research found a relative reluctance on the part of racialized groups to participate in genomic and data research. There's obviously also, this ties into a history of over-research and lack of benefits. So Indigenous communities often complain that they have been over-researched and that medical knowledge is never translated into tangible benefits for their communities. Oh, sorry. And Nikki Tiffin has argued that in low trust settings, a higher standard of consent is necessary. So while we might accept broad consent, future unspecified consent in high trust communities, in low trust settings, that's not acceptable. We might need tiered consent. We might even need specific consent for individual studies. She's referring to low and middle income countries where there's more distrust of government, and there aren't the same kind of necessarily institutional protections like the General Data Protection Act that you might find in the EU, or kind of privacy and data regulation that you might have in New Zealand. And she argues in those contexts, you need a much higher standard of consent. So we're left with this tension between higher standard of consent and low trust settings, but a real need to include data from those groups in our research. So I said that we tend to approach this from a research ethics perspective. Everything I've talked about so far is really research ethics. I've argued that actually I think a public health ethics approach to data research is much more promising. And it's super helpful for me that Lisa's already talked you through some of the key principles of public health ethics. Research ethics tends to focus on known individuals and is primarily focused on preventing harm to research participants. That's quite a narrow focus, and I don't think it really captures a lot of what's going on in relation to genomic and big data research. public health ethics has the conceptual tools to focus on power, equity, justice, and the distribution of benefits. Has the expertise to focus on groups. What's unique about groups? How do groups in society relate to each other? What are the group harms? This is really important in relation to big data research, because in relation to most clinical research, what we're worried about is harms to the participant in the study. They're taking a new drug. Will it be harmful? In relation to data research, there is in my view, very small risk of a privacy breach to the individuals whose data is used. But most of the harms are actually collective harms. They're group harms that would apply to groups in the future. So if, for example, we let insurance companies have access to our genomic data, they develop new predictive models to predict who is going to have early mortality, they might exclude groups from insurance. The harms are downstream and they relate to human beings that weren't involved in the research at all. And public health is just much better situated to consider those kinds of harms. The focus is much longer term, which is great, because as I've said, the trajectory with kind of big data and genomics research has a much longer time frame. And public health is really good at thinking about how, not just what. So how do we build trust? How do we engage in communities? How do we involve communities in decision making? How are we accountable to communities? So I think public health has a range of conceptual and ethical tools that mean we should really be locating a lot of our debate about AI and big data, not in research ethics, not in clinical ethics, but in public health ethics. And so let's talk about quickly an example of how we might action that. So in relation to the IDI, which is, I'm sure you're all familiar with, a platform for sharing data about New Zealanders, we have heard from Indigenous communities around the world that we don't just want to be fair with our data. So FAIR is a model that focuses on whether data is findable, accessible, interoperable, and reusable. Indigenous communities have also suggested we should have an equivalent model called CARE, which is around collective benefit, kind of Indigenous data sovereignty around control, responsibility, and ethics. And I think the Ngāi Tikanga Pahere model at IDI is a really good example, not of focusing on individual consent to use data, but in focusing on building trust, demonstrating trustworthiness, and collective control of how data is used at a governance level. And I think this is a much more promising way forward. So the IDI has a 5 safes model. That's a really standard model for accessing data internationally. In addition to that, they've recently introduced this Ngā Tikanga Pahere review, which is a review looking at IDI studies from a tikanga Māori perspective. And I think that's a great example of implementing a more collective public health ethics set of values into how we manage data. So I'm going to stop there and see if we've got time for a few questions. And I'll stop sharing.
Thank you, Angela. Really interesting, and it's been a big suite of highly relevant topics this morning, and thank you for your contribution. We've got a question here concerning data collection. What is your opinion on race, often as a substitute for class when examining racial disparities in health, and what evidence supports this practice and why?
I don't think there's a lot of evidence. I think it's an overhang. I mean, race is something, because we think of race as reflecting kind of biological difference, so skin color, for example, it's something that is seen as more visible and easier to measure perhaps than class. New Zealand and kind of health disparities as a result of income and poverty, for example. Obviously, health disparities and systemic racism intersect, so they compound. But I think there needs to just be a lot more work on developing clear categories for what it is we're interested in. If we're interested in ethnicity and different cultural practices that influence health, for example, that's appropriate. In relation to biological differences, it's really hard to pin down something that adequately captures the genetic variation and difference we're interested in. Because even, if you look at races, in quotes, there's more genetic variation between members of that same race than between supposedly different races. So there's a lot of work to be done there.
And a follow-up, would you agree that with the statement that class has been the ignored social determinant of health?
Well, I guess my background is in ethics. I'm not an epidemiologist myself. And so this, I suppose I look at this stuff as a consumer of all the papers that you guys write. I think, at least in New Zealand, there's a reasonable attention to health disparities by levels of deprivation, income codes. Yeah. So I guess I don't feel like I'm very well positioned to answer that specifically in relation to public health research.
Okay. Frolin, you have a question. You've got your hand up. Can you unmute, please? Oh. Well, while we're waiting, has anyone else got a question for Angela? Got a hand up? No. So, Angela, a question that the use of big data, AI, and the ethics of it. I mean, it really comes down to, should we be sort of pooling all this data together? The ethics of essentially mining data just for the sake of mining it. What's your view as an ethicist on that?
I mean, I don't think mining it just for the sake of mining it is appropriate. I suppose I think we should be thinking of health data as a public resource and managing it as a public resource. I'm quite skeptical of efforts to use individual consent as the key ethical governance tool. Consent matters because consent does transformative ethical work, right? So if the surgeon comes and cuts me open without consent, that's assault. If I consent and I understand what they're proposing and give my permission, then them cutting me open is no longer unethical or illegal. So consent's really transformative there. But I think we have a very, very thin operational concept of consent in relation to data. So someone will say, oh, the patient ticked a box saying, we can use the biological samples for future unspecified research. Or the patient ticked a box saying they understand that all their clinical information is used for research when they signed up with this PHO. Or I clicked the terms, I clicked agree to the terms and references when I downloaded an app on my phone. I mean, that's not doing any transformative ethical work, right? And that hasn't changed a practice from being unethical to ethical. And so I guess I'm quite skeptical around individual consent, and I'm much more interested in how we could use governance structures to manage New Zealand's data as a health resource for the future and distribute the benefits of that equitably.
Thank you. Any other questions for Angela? You've still got a hand up, but nobody can talk. Well, there doesn't seem to be any more. So thank you once again, Angela, for a wonderful presentation. Thank you for your contribution to the PHONZ conference. Thank you.
So I beg your pardon, we do have one question left in the Q&A, and a very late hand up there from Emily Valley, but there's one in the Q&A if you'd like to take it.
Okay. Oh, okay, here we go. Can minorities ever get sample sizes as big as the majority?
No, you won't be able to get sample sizes as big as the majority, obviously. And so I guess there's a couple of things going on there. I mean, if you look, for example, at the fact that 95, so maybe 90% of all genomic data that's been collected is from European ancestry, from people with European ancestry, that's so distorted, right? And there's, large other populations in the world. So there's, Asian communities, for example, Asian ancestry. And so Singapore, who I'm working with, is looking at developing the premier genomic data set of Asian genomes. And they're ambitiously hoping to sequence 1 million Singaporean genomes. So that's sort of 1/5 of the overall population and nearly 1/3 of the resident population in Singapore. So hugely ambitious. And so there's a lot of work that can be done where we're not talking about, necessarily very small minority groups in terms of genome representation. So obviously with some populations, that's going to be easier because there are more people than others.
Sorry, we've got another question now.
Okay.
And two compliments, great presentation and thanks, very interesting. Given our data in the healthcare system is based on ethnicity due to differences in access, are there any non-biased AI systems even possible?
No, great question. There is no non-biased AI, because AI is based on humans and there are no non-biased humans and no non-biased human systems. Our justice system is biased, our health system is biased. So there's lots of really interesting work on normative conceptions of fairness in relation to AI at the moment. So some research suggests that, you've built this AI model, you want to use it because it's more efficient, it gives you more utility, right? It allocates resources more effectively. Someone had asked for an example about an AI model in public health. So one that I was looking at with some colleagues in, again, Singapore, was looking at an AI model that could help predict effective use of antibiotics. Now, you can either set that model from a clinical ethics perspective to only give antibiotics when it's beneficial to the patient, or you could set the threshold quite differently from a public health ethics model, where you might actually be prioritizing minimizing antibiotic resistance, set that much lower. So that's an example of, so maybe you've developed this model, it's useful, you want to roll it out because it's going to deliver some sort of good for the community. And then you've got questions about bias, because it's never going to be representative data. And even if the data is representative of the community, it's still going to reflect all the biases within the health system anyway, right? Because health data isn't data about health, it's data about how an individual interacted with the health system. So that's a social interaction. So then, one thing you could ask is the AI more biased than our current clinical system? But to assess that, you're going to have to trial the AI and evaluate it, and that's really expensive. There's lots of techniques, like 20 different accounts of fairness that you can use, statistical fairness, to try and fiddle with the model. Often what happens is if you try and improve predictability for a minority subgroup, you decrease accuracy overall from the model. So you've got this really explicit trade-off between kind of an equity fairness consideration and a utility consideration. And there's no simple answer to that at the moment. And I think that's also context specific. Again, for me, this is kind of why public health is useful, right? Because the degree of bias we're prepared to accept might be context specific, right? So there's a lot of talk about differential access to surgery in New Zealand at the moment for Māori and Pacific patients. We've got the new equity adjuster model. Might be in that context that if the AI model is going to be biased in relation to Māori accessing surgery, we're like, no, we're not prepared to roll it out on those grounds. If, on the other hand, it's slightly biased towards women in relation to some sort of cancer treatment, but it's really beneficial overall, we might say, yeah, we're actually happy to go with that. But that's kind of a political and social decision. It's not something that you can necessarily address from the kind of statistical end with the model itself.
Well, thank you again, Angela. Wonderful presentation, and thanks again for your contribution to the PHONZ conference.
Oh, it's been wonderful. I've enjoyed it so much. Thanks.
Good. Thank you.
Right. Yes, it's over to me for sharing. Am I showing up here? Am I on mute? You can still see Angela.
I can see and hear you just fine, Ron. You're good to go.
Oh, excellent. Very good. So I'm taking over from Barry on chairing duty for the not quite afternoon session. So we're going to go through 4 speakers, and after the first speaker, you've all heard of elevator pitches, but it looks like we've got an elevator lunch break of 10 minutes. So hope you brought packed sandwiches. But first up, we've got Dr. Mat Walton from the Institute of Environmental Science and Research. Matt is a science leader for social systems at ESR and has previously been a lecturer in public health and policy, and a policy analyst in local and central government. Matt's research focuses on the application of systems thinking to public health policy, intervention design and evaluation. And his presentation title today is Systems Thinking and Public Health Intelligence. Over to you, Matt.
Tēnā koutou hu mai nei, thanks for that introduction. I'll just get my, do the right screen, hopefully. Great. And let me know if you have any trouble hearing or seeing anything. Yeah, thanks very much for inviting me along to this conference. Such an interesting collection of speakers. As Ron said, I work at ESR as technical lead and social and science lead for the social systems team at ESR. I assume most people know what ESR is, but just in case, we're one of the Crown Research Institutes in New Zealand. And amongst other things, we have a public health focus. It's one of our key things we do through infectious disease, epidemiology and research, food safety, water quality, look at environmental contaminants and radiation safety. Within that, we have our team of social scientists within ESR, and we work quite widely to consider how people interact with their environments and with health and social services. So that might be in kind of service design areas, or as Ron mentioned, evaluation as well. And we specialize in applying systems thinking approaches to our social science work, including to some degree thinking about social and ethical implications of new technology and new approaches to public health surveillance, which I'll talk about a little bit as we go through. So what I'm going to talk about today, there we go. I'm going to very briefly give you about my perspective on this. I want to be upfront about what I am, what I aren't. I'll go through what systems thinking is, and I'll use two different systems approaches to frame some questions about what public health intelligence might be trying to do, and perhaps what it should do from a slightly ethical perspective. I'm also not an ethicist, so this is very much a social science perspective rather than a detailed ethical analysis. On the screen there, hopefully you're seeing, I assume you're seeing, you are seeing it, aren't you? Yes, good. Some icons here. We have the Nokia 3310 phone. We have a picture of the Sydney Olympics, and I'm sure you're all fans like I am of the song Who Let the Dogs Out by the Baha Men. These are all things that were huge in the year 2000, which is about the last time I did anything that could be called epidemiology. So I just want to be clear that I'm speaking here from a largely policy perspective and theoretical perspective of applying systems thinking to public health surveillance. Most of my experience is more in qualitative monitoring and evaluation approaches. Okay, so what is systems thinking? I'm just going to just here showing one definition. There are many. This is from Danella Meadows, who's a pioneer in system dynamics, and she describes systems thinking, a system as a set of things, people, cells, molecules, or whatever, interconnected in such a way that they produce their own pattern of behavior over time. So what we're talking about here when talking about systems thinking then is an understanding that the topic or phenomena of interest to us is produced through interaction of many things. And also that we want to focus on behavior over time. We're not interested in just looking at a single point in time, because that doesn't give us a systems view. Also on your screen is a picture of a strange attractor. So this comes from dynamical systems and chaos approaches. And I've just put this up here to show that some systems exhibit behavior over time that produces some interesting shapes. The importance of this is that if we do take 1 or 2 or 3 or 4 points in time as our reference, it might look like the system's actually changed in nature, but sometimes systems oscillate between certain states, and what looks like a change in behavior might actually just be a certain point in time in that oscillation that we've captured. This, of course, isn't new to public health thinking. We all are used to looking at trends over time and understanding our data in terms of those trends. But sometimes it's lost on those who might draw on our data to make arguments for their own position of what should or shouldn't be done. So one of those challenges is to be upfront about what our data does doesn't show and doesn't support. Again, just as a bit of background, this is a map that has been created, and this isn't the latest version, but it gets updated every few years, of complexity sciences and trying to show some of the different traditions within what can be considered broadly as systems thinking and complexity sciences. Each one provides us a different perspective. Some of them are very close together, and some of them are quite far apart in how they see the world. And really today, I'm gonna be talking from a small part of this this huge field. So again, just take that with a grain of salt, really, that someone else doing something from label to systems thinking might be giving you quite a different perspective. Okay, so I'm going to draw on two models, two systems approaches, and think about what public health intelligence might mean from both of those approaches, and then try and draw together some really summary points about how that might support our work and thinking about ethics in our work. So the first approach is from the field of field of organized operational design and management, and it's known as the viable systems model. This was developed by Stafford Beer in the 1970s and has been used extensively since within studies of organizational design and operations research. And the key idea really is to consider how an organization remains viable within a changing operating environment. So here is a very simplified diagram of the viable systems model. If you Google viable systems model, you'll get lots and lots of different variations, but they all essentially have this structure. The model consists of 5 types of systems: operational systems, coordination system, control system, intelligence, or often referred to as planning in viable systems model, and a policy system. The idea is that all of these systems interact in certain ways, and they interact with an operating environment as well. And a central idea is that for a system to be viable within a changing operating environment, we need requisite variety. So the variety in the environment should be matched by the variety in the organizational systems. In other words, we need to be able to respond to the complexity of the environment we're operating in. So, for example, a hospital, primary care, disability support services, they all, as operational units, interact themselves with the operating environment, but they're largely blind to each other. So this is why we need a coordination function, which helps the different parts of the wider system, and we could be talking about the health system in this case, to see each other and to understand what each other is doing. The coordination function and that function of helping different operational areas to be seen is important also for supporting control systems and functions. And control here really means distributing resources between different operational areas to meet needs, and also an audit function around quality and control there. Intelligence is focused largely looking outwards at that operating environment and trying to identify changes in the operating environment that might require a change in goals, so a policy response, or a change in allocation of resources, which is a control response, or change in operating procedures, so an operational response. And I think for our purpose, something to take away from this model is the idea that if information and, more importantly, intelligence doesn't only sit at one point in the system, the thing that I've labeled intelligence. Each operational area requires intelligence, both to look about its own operating environment and use of resources within it. The coordination requires an internally focused intelligence function, as does control, and the policy requires a sense of what intelligence means for the goals of the system more broadly. And the system won't function well if information and intelligence functions are not operating at any particular part of the system. So the implications are that we might locate our kind of public health intelligence systems at a central agency somewhere, but if that's not getting out to the regions, if that's not getting out to the lower level of on the ground operational units, then we won't be able to adapt to that changing operating environment as we might need. An example might be, if our infectious disease surveillance systems picking up a changing trend in STI and notifications, for example, the viable system would suggest that those providing services to both treat and prevent STI need to have this information as soon as possible for a response. And so it's a coordination function. But attention also needs to be paid to the capacity of these services, which is a control function, and consideration whether the trend requires a different approach entirely to STI or just an increase in what is currently offered. So those are both planning and policy functions. And from a very broad ethical perspective about are we doing the right thing? As we heard actually with our last speaker, is it ethical to collect information if it's not being used? And from a viable systems perspective, that use is about helping shape our operational environment and responses to the needs of the changing environment. Right. So some of the implications of the viable systems model, if we're taking this approach to systems thinking. One is that information supports multiple functions. So our operations need to be able to see other operations through the coordination. Our control function needs to be able to have the information required to change the allocation of resources between different operational areas if needed. And that intelligence function needs to be able to identify that changing operating environment and support policy considerations of those changes. An underpinning assumption of the viable systems model, though, is also that we need to assume there's increasing complexity of the operating environment. From a health perspective, we might consider that as we get increased knowledge of environmental risk and protective factors and the interaction of different environments with people, we need to be able to integrate that knowledge within our operating environment and our health service responses. Likewise, a greater attention to equity often requires a view of smaller populations. And so different data sets that have, as we were hearing, different challenges and level of quality of data. And fundamentally, that our operational responses need to match the complexity of that operating environment and that increasing complexity of the operating environment, which really suggests that we need to avoid ideas of getting back to basics or defining core services that are the basic functions of a healthcare system and ignoring the others. And it's always tempting when we have limited human and financial resources to think, well, what are the absolute basic services that we can provide? But the viable systems model would suggest that we need to understand the increasing complexity of the environment and respond accordingly. It also suggests we need to increase our view of multiple causal pathways and co-benefits, because it's a lot easier to say, actually, we need to keep on investing in responding to complexity if we're understanding the co-benefits between some of those multiple causes of ill health and of wellness. So what might be a little different about the viable systems model approach is that it suggests a well-working system requires a good interaction between all the parts of the model and paying attention to the changing environment. It would challenge an approach of command and control of our healthcare system through tight KPIs, for example, which tend to be internally focused. And that system-wide goals need to be well understood across the whole system. And we can see elements of this thinking behind the recent health system reforms in New Zealand, the changing of DHBs into a national Te Whatu Ora service, with one of the intentions to be able to allocate resources at a national level with a national level oversight rather than many local intelligence systems. I'm now going to move on to the second systems perspective, which is critical systems heuristics. Now, this is different to the viable systems model in that the viable systems model sees a system as a real collection of things, services, information flows, people, and resources. Critical systems heuristics, on the other hand, is much more interested in how different perspectives, different people taking different perspectives, make boundaries for their understanding of a system. So it assumes that we can never, because everything's interconnected, we can never have a full understanding of the complexity of the world. We always construct boundaries to make the world knowable and actionable. But those different boundaries have power. So if we think about different perspectives, much like these spotlights, each perspective acts to illuminate areas while keeping other areas in the dark. And a lot of effort in politics and policy and service design and even design of monitoring and data systems seems to be an effort to justify why I have put my spotlight pointed in the direction I have, rather than asking, what can you see in your spotlight? What can I see in my spotlight? And creating dialogue between those to have a fuller understanding of the situation. And Ulrich, who developed critical systems heuristics in the 1980s, really intended the approach to support dialogue between different perspectives, as well as providing a critical analysis tool. And one example I often come back to is under the Labour government of the mid-2000s, district health boards were given a target of reducing prevalence of smoking within their populations. Under the national-led government elected from 2008, the target changed to the number of patients within hospitals offered quit smoking advice and services. There are values underpinning those different targets, of course. One reflects the social democratic ideology that government can intervene for the good of whole populations, compared to a more liberal conservative perspective that government should provide some key services, but otherwise let people make their own choices about their lives. Neither target is easily characterized as completely right or completely wrong, but each drives the health system response at the expense of the approach promoted by the other type of target. So there's these two spotlights going on, and how do we gain knowledge between them all? Practically, critical systems heuristics, Ulrich identified 4 domains where we would want to do some questioning about how people have drawn their boundaries around the system. Within that, there's 12 sort of question areas that Ulrich asks. And of relevance to those of us interested in research and public health intelligence, knowledge is seen here in several ways. It's their own domain of knowledge about what expertise is defined as being an expert, who gets to define expertise and what expertise is accessed, but also under motivation about how improvement is measured, which includes assumptions about what success might look like. So drawing upon critical systems heuristics, I think for public health intelligence, we might want to consider these questions when establishing our approaches to information systems. What are the goals? What are we trying to achieve? Who gets to define the goals, and therefore who's excluded? How are those most impacted included in decision making? Who gets to decide what information is relevant? What areas are thrown into shade by our decisions? And how is dialogue supported? And I'm just going to give a very, very brief example. So a few years ago at ESR, Suzanne Manning and I did just a small scoping study around the emerging area of wastewater-based epidemiology. At the time, ESR was doing illicit drug surveillance using wastewater epidemiology. It was just when COVID was starting and we're developing COVID responses to wastewater epi, and there was interest in it more generally as part of the public health surveillance suite. So using critical systems heuristics, we're able to basically say through some interviews, people were pretty keen on wastewater epi if it provided benefit at a population level. There was certainly less support if the data was given to private companies such as insurance companies that might then start making decisions using that data. And if the motivation was around equity and not stigmatizing certain populations. And in line with that, there was more support for public health uses of wastewater epi than there was for justice sector uses. But there was also an assumption that ESR should have, would have, and of course must have robust policies and procedures to support the positive use of information. So people are saying, assuming ESR as a professional organisation has got that in place, then we kind of agree with the motivation. Likewise, ESR was seen as trusted experts. But there was certainly concern that when we're taking samples from communities, members of those communities should also be involved in making sense and understanding what the data means. And then legitimacy here was really tied up to all those other areas about what is the motivation and how are we going about this in a good and ethical approach. So we found this quite a useful framework for thinking through broadly some of the social ethical concerns of this sort of emerging technology. So I'm just coming to summarize now. I mean, I think if systems thinking in general and the two approaches I've talked about, we really need to think that, and remember that our outcomes of interest are always the result of interaction of many parts. And our actions in the system are also going to influence other parts of the system. So we need to pay attention to what our work interacts with and the operational systems that they're interacting with and the multiple roles that information and intelligence play in a functioning system. We should always be looking for opportunities for our work to support actions, not just information for information's sake. And to do this, we should look internally about what services are provided to whom and how well, but also externally to understand diversity within the operating environment. And we also need to be aware of the power embedded in choosing what data to collect, how to analyse and how to share. And the decisions reflect perspectives and simultaneously give and remove legitimacy from different perspectives. So my last slide now. Again, I'm not an ethicist, but taking a couple of the basic, broad ethics principles around avoiding doing harms and providing benefits to others, it seems logical to conclude, unless we're aware of how our work interacts with other areas of activity as a system, we may inadvertently cause harm or at least not achieve levels of benefit that we might hope for. And if you remember nothing else from my talk, except for that I referenced who let the dogs out, I think there are two questions that might help our work more broadly that are backed up by these systems approaches. One is thinking, does our work support diverse responses to complex environments? And that includes diverse needs of diverse communities and the interaction with those local communities with central resource decision-making. And does our work support dialogue between different perspectives? And if not, then we're not paying probably enough attention to the power embedded within our work. Thanks for your time. Kia ora.
Thank you, Matt. That's I had no idea there were so many systems models in play. Pretty inescapable that public health itself is all about connectivity, and are there frameworks that you think that would be more suitable both to the reorganization of public health services and public health from a systems perspective. But I guess, no, I don't want to ask that question. I'm going to change because I can do that. The other part is our data and what we collect, and we don't want to over collect. But if part of that process is increasing complexity and the ability to change dynamically, that has a lot of implications for how we design things and what we collect. And if you got any comment on, we're about to design all these new data systems to collect what have you, what your perspective from a systems model might say to that.
Yeah, thanks. I think there's not an ongoing tension, right? That we constantly feel we need more data to support our actions. And certainly I'm not saying that's not true, but there's also at some point, what is enough data to support action? So I think from a systems perspective, one of the implications is that we never have complete information. The operating environment is always changing. When we intervene, we change the system, hopefully for the better, but not always. So actually it's about not having perfect systems, but about having systems that are giving as close to real-time feedback as possible, but also integrating data, sort of administrative data and survey data with people's experience. So really it's about interacting of that qualitative and quantitative kind of data in view of the system as well.
Thanks. Question here. Are you aware about attempts, current or historical, to develop a systems model, semantic model, ontological model, graph model of public health in New Zealand?
No. But that would be interesting.
So that is all our open questions.
Right.
Last chance. I think we might have extended our 10-minute lunch break to 15 minutes or so.
Yes, sorry, Rod, there is one more question in the Q&A from Dufford, who asks, can you explain how you used the heuristics model to involve communities in the WW sampling example you gave, and what does this look like on the ground?
Yeah, that was very much a small scale scoping bit of research that was simply done through key informant interviews. We have played around with sort of wider data collection informed by those critical systems heuristics in other projects. You can do that by a survey, via focus group, whatever, but I wouldn't say we've managed yet to get really effective on the ground in an ongoing way community engagement using that framework.
Okay, thanks, David. Matt.
Thank you.
Yeah, really fascinating presentation today, Matt, and look forward to seeing more about system dynamics. So we will see you all back here at 12:15. Thank you very much. Associate Professor Anna, yes, in progress. Anna Matheson from Victoria University of Wellington, who currently teaches health policy and systems. Anna has a public health background with a focus in health inequity and the social determinants of health, and has a particular interest in the relationship between policy, systems and communities and the application of complex theory to social change. Her topic today is complexity theory and whole systems, lessons for public health action. And I will pass it over to you, Anna.
Unmuting myself is probably useful. Can I just double check here whether I can do notes? I don't need to, but just if I can, is that all right? Just before I begin? anyone gonna?
Notes.
If I can do if that works, does that show you?
We can see your first slide, yes.
You can only see the first slide?
Yeah.
Wonderful. Okay, that's good news. All right. Tēnā koutou katoa, ko ana Matheson tōku ingoa no te herenga waka aho. And I'm going to talk about complexity, just a little bit about complexity in whole systems, and then some things which I've learned about public health action from this perspective. But first up, I just want to get this out of the way. Now, this is something that all through my career, I have people saying to me, but Anna, you know, isn't everything complicated? And I say, no, and I say, no, things which are complex are not complicated. They're different. So when something's complicated, when something's complex, it's about it's about a natural behavior of systems where there's sort of features like self-organization and emergence. So it's complexity which drives things like birds flocking, biological evolution, human consciousness, what we're seeing, the nature of climate and other planetary systems, as well as interrelated health, social and economic systems. A rocket or a car is complicated, so it's different. It's about these systems which have this kind of behavior. So I'm just trying to get something out of the way there. There we go, that's better. So understanding systems as complex offers a bunch of ways to think about them. So think about issues. So it gives you ways to think about what is predictable because there's this type of behavior that goes along with it. It gives you ways to think about uncertainty and unintended consequences, about causal emphasis in complex systems, relationships, interaction, and initial conditions, sort of causal, parts of the causal processes. Gives you ways to think about evolution and adaptation, nested systems and multiple scales of systems, whole systems, and also system context. So an important concept that I've sort of come to is this idea of whole systems. And you've probably come across the old Indian parable about the blind man and the elephant, where each blind man examines the different parts of an elephant to try and determine what it is they're feeling. And needless to say, an elephant is not long and bushy or hard and sharp. So the moral of the story was originally about religious tolerance and the idea of partial knowledge based on your perspective, but it's also come to be used to illustrate that complexity idea that the whole is greater than the sum of the parts. And this relates to this idea, which you see in political science, and was one of the only things I took away from my political science degree, actually, was this idea of bounded rationality, that like decision-making and being rational actually only occurs in these boundaries of actually what you know and what you don't know. And I think that's important for understanding individuals, but also understanding sort of our collective knowledge. So as these boundaries, our collective boundaries of knowledge are shifting because of this huge amount of knowledge we now have about ourselves and about the planet, I think that this shift to whole systems thinking is really becoming more evident in our frameworks, which are becoming more and more about seeking to make sense of those relationships between nested systems and between scales. But as my friend and colleague, Sione Tuitahi reminds us all that, planetary health as a whole system might be new to many, but it's old to Indigenous peoples. We're one with Mother Nature, whanua, the systemic coherent web of life. So also evolving has been the complexity sciences. And so this year, and I'm not expecting you all to look at all the pieces, although you could afterwards go and have a look at this, but this is a system map of the evolution of the complexity sciences over the last century. And it was put together by Professor Brian Castellani, who's head of sociology at Durham University. And there are few things which are really interesting about this map, but the useful point that I want to make for this presentation is about how the complexity sciences have become more and more applied and more prominent in the health and social sciences in recent years. So that's what you'll see if you could see those little bubbles and things. These books, which have been important to me, also capture some of that evolution. So early 90s, people started to put together lots of the things which were being learned through the complexity sciences and about the behaviour of systems, and they came up with complexity theory. And so this was 1992 that a sort of a popular book was published around trying to articulate that theory. Less than a decade later, a lot of work started to be done using complexity theory to try and understand its relationship to the social sciences. And so this is a really great book by David Byrne, also from Durham University. And then this is really interesting. So 20 years later, and so this is a New Zealand book written by Rosemary Hipkins, who is the mother of our Prime Minister. And in the book, she argues and illustrates just how actually we need to be teaching complex systems thinking right throughout our school curriculum. And it's a really lovely book if anyone's interested in that kind of thing. And now, which again just shows where we're at with complexity and complex systems. I'm part of this wonderful group, Te Pūnaha Matatini, which is one of New Zealand's Centre of Research Excellences, and this one's focused around complex systems. And so Te Pūnaha Matatini brings together lots of people from a whole bunch of different disciplines who are all interested in complexity and complex systems. So in public health, which was the discipline I was trained in, systems thinking tools and methods have become much more popular, probably, I'd say the last decade, and then even more so in the last, like, just, 2 or 3 years even, I would say. So there are lots of different ways that systems, tools and methods are being used. There are quantitative tools like modelling, like COVID. There are qualitative tools, causal loop diagrams, there's mixed method tools, there's participatory type methods. So a lot of mapping and a lot of modelling, a lot of network analysis, those kinds of things. But what I have become interested in from this complexity background is where it's being used to understand social change and frameworks for change and system change. And so the next part of the presentation, I could talk to you about sort of more theoretically about this and about intervention, but I won't. I'm instead going to talk to you about Healthy Families New Zealand, which is a community health initiative which was set up to create system change. So if I could see you all, I'd ask you if you'd heard of Healthy Families New Zealand, but I can't see you all, so I'll tell you about it. So Healthy Families New Zealand there are 11 teams in 10 different geographic locations around the country. Each of the teams is located in a other local organisation, and so 4 of them are Māori-led, and they're in iwi organisations, whānau ora. There are 3 in local government, I think, a couple in the regional sports trusts, and there's also 2 located in Pacific-led social change organisations. And these little blurbs on this slide are how the initiative describes itself. So they see themselves as bringing community leadership together in a united effort for better health in the places we live, learn, work and play. And so clearly, you know, that's responding to the evidence that the Commission on Social Determinants of Health has said, that where we need to focus prevention efforts. So the Healthy Families New Zealand approach focuses on addressing the underlying conditions that impact our health and well-being in order to reduce the risk of preventable chronic disease. All of the Healthy Families New Zealand locations are connected through this common approach and principles to create a prevention movement. So locations, Healthy Families New Zealand locations, they go from far north down to Invercargill and many in between. And on this slide, you can see the different organisations that they are embedded in. In this slide, like that book on case-based methods and the other article title, they're related to the evaluation which I've been leading, which I'm not going to talk about here other than some insights from it, but we also used complex systems thinking to underpin how we carried out the evaluation as well. So just a little bit about the history of Healthy Families New Zealand. So it was commissioned by the Ministry of Health in 2014. It was modelled after an Australian initiative called Healthy Together Victoria. It was refunded in 2018 and again in 2022. The evaluation has been funded alongside the initiative. So key features of Healthy Families New Zealand are that it was trying to create a systems thinking and acting workforce. It was focusing on creating strategic leadership groups, prevention partnerships, and the national team, located mostly at the ministry, now at Te Whatu Ora, was always seen as part of the initiative itself. And the teams operated with some shared guiding principles, and they were implementation at scale, collaboration for collective impact, equity, experimentation, adaptation, and leadership. And I guess, so from the evaluation point of view, this is kind of a brief overview of what we were seeing the teams doing. So we were seeing them building on what is already going on in their local communities. They were operating as backbone organisations to support shared goals around health and well-being. They were incentivising more collaboration and collective action. They were sharing and developing tools and methods to gather local insight and to sort of elicit local action. They were working to distribute and link up leadership for health, and they have been learning about system change. So as the initiative's gone on, the team's understandings of what system change is has really deepened. While at the same time, the world around them also has become more interested in what systems change is, and there's been a bunch of sort of tools and heuristics which have become more widespread. And one of those which has become really useful for the teams is this one here, 6 conditions of systems change. And this heuristic is derived from the work of Donella Meadows. So some of you may have heard of her. Certainly if you're interested in systems thinking, you would have heard of her. And she's done some amazing work, including looking at, so what are the key levers of systems change and what are the most effective places to intervene in a system. And so this is what this model, which ended up being adapted by others, is trying to show. So the evaluation has found a lot of that there's been a lot of local success with the initiative over the years. There's been spreading healthy settings and processes like workplaces, marae, schools, changing funding criteria, that kind of thing, championing healthy local and national government policy around smoking. Recently, some great work around alcohol, food, water, urban design. Projects that restore and reconnect with the natural environment. There's been a lot of building of local communication capacity to share local information and practices. There's been influencing primary and community health and social care relationships, and there's been growing movements to influence water and food systems. So a major achievement, which was particularly evident in this last phase of the initiative, has been the increasing influence of Māori worldviews and local and traditional knowledge on many aspects of the work of the teams. And so this has shown itself in the work that they've been doing around food and water and in the environment, and also the more holistic approaches that teams have been taking. Now, this quote sums this up really nicely, I think, just how this has been important for the teams, because all of those practices and what we found has been so interesting is that from the Māori-led sites, a lot of these ways of working and practices have become really important to the non-Māori sites in particular. So this is this quote. So we went through a bit of a process with, with healthy families, including why the emphasis on maramataka, because it didn't seem to fit naturally against what we were contracted for. But it's been the key that's really captured the imagination and the heart of the community, and it grows people's cultural confidence and identity. And then they speak up, and it encourages people to have a voice about many things, including their water. So across all the locations, food systems has become a very strong priority, with work supporting local kai collectives, projects to distribute food such as Pātaka Kai and food in schools, projects to regenerate soils and improve food cycles. But perhaps more important has been the movement to improve local food systems that's been created. So this report that you can see, I think it might be on your right, the National Kai Impact Report, was a report where all of the 10 teams from their diverse communities brought together all of the things that they were learning about food systems, about practices in their food systems, and what was working, what was not working, and they brought it together in a national report to share it. And so the idea was that, how do we keep this momentum going? How do we share this both with each other and with those making sort of bigger national decisions as well? So the teams have been involved, not just food, but a bunch of other things as well. And they've been sharing and communicating this knowledge and the practices, across their diverse community contexts. So there've been a lot of work around smoking, around, as I said, there's this real recent work around trying to really make a difference to alcohol, which they're really making some progress, and around getting people active, and particularly with a focus on children and around play. One of the things, the first 3 years of the initiative were mainly focused on those sort of chronic disease risk factors. One of the things which ended up being really apparent to all of the teams was just how pervasive mental health issues were and how nothing much was being done. So in the next contracts, mental health became a focus, and there's been quite a lot of work being done around mental health as well. So they've been also sharing what has been important for getting stuff done. So not just the topics of what they've been doing, but also the way that they've been doing things. They've come together to share what they've been learning about systems change. There's been a lot of work highlighting the really important role that local government plays in, should play in health and well-being, and certainly the teams have had a real focus on local government, and the unique way, the unique contract relationship between the national team and the local teams, which has been a real facilitator of adaptation, and the successes in the initiative has become something that people are really interested in as well. So the evaluation identified a number of factors that are contributing to systems change. So those, tangible local changes that I talked about, that sharing practices across diverse communities, the development of this uniquely skilled and sought after workforce, working on how to do collaboration better, which we've found you need to be intentional, it has to be resourced. Distributing and joining up leadership, better leveraging of available organisation and resources locally, better local engagement methods, and that responsive policy community relationship. Also really important, and if you go back to that diagram of the triangle with the mindsets down the bottom, it really has been interesting to see how mindsets and paradigms have influenced, what the teams have been able to do. So, although it's difficult to evidence, certainly sort of the mindset setting of a lot of this work has been really palpable in a lot of ways. And I guess if I was thinking about the biggest challenges, I think, in mindset, one of them has been about just that acceptability of communities being the holders and creators of expert knowledge, the acceptability of systems thinking, and the pervasiveness of practices that are associated with growth, like competition and individualism and that kind of thing, which was, one of the things that the initiative was set up to try and disrupt, really. Some of the facilitators of the initiative in making progress shifting these mindsets have been time and continuity, and also perseverance, because to keep the continuity, it certainly has required perseverance from, many individuals in the initiative and around the initiative. That idea of building knowledge through practice, I think that's been really powerful. And I think the pandemic also has been a real facilitator. I think it raised the visibility of community action. And I think it also showed the utility of systems thinking in a lot of ways, because of what we were seeing with the reproduction of inequality and the weaknesses in many of our systems. So I love this quote. So real and equitable progress requires exceptional attention to the detailed and often mundane work of noticing what is invisible to many. And I think that this is, really a real central problem to us making real progress on equity, is the invisibility of things which are local, the lack of value and the lack of appreciation of the sophistication of local practices, of relationships at the local level by those who make decisions and are in policy organisations. So for local practice, how the general evidence can be put in specific practice, I think it's seeing the teams share and come up with, such amazing efforts in that area has been one of the real successes, I think. And so that potential for local community practice is to be transformative. Valuing existing relationships, building on what's already going on in communities. I think, valuing and understanding that there could be this relational community infrastructure across the country. And valuing local organisation, that you can have local organisation that is effective, and it's not pretending that already policy doesn't influence how communities organise. So we should be able to facilitate communities to be organised better around health and well-being. And I think that's looking like I am almost at 25 minutes, so that's probably my time, and I think I will leave it there. Just a few thanks to the Healthy Families New Zealand Workforce and National Team and to the evaluation team. And I've also got some further resources and things there. So thank you.
Thank you very much, Anna. It was amazing work across that. One thing that comes to mind, and it's not my realm, so it might already be done, people might be all over this, but the Healthy Families New Zealand work and the voice of whānau and locality up from the community seems to parallel where MPHS intelligence capability and localities work is going. To your knowledge, has there been cross collaboration between localities and Healthy Families New Zealand, because they feel very similar in what they're trying
to...
Well,
I do suspect that actually some of the underpinning thing about localities has been influenced by Healthy Families New Zealand, which has now been around for 8 years and produced a lot of learning and insight. I also know, which is one of our, problems with uncertainty, that each time the contracts roll over for Healthy Families New Zealand, of course workforce gets nervous about whether they're going to have a job again, and usually decisions are made without, and so at those times often the teams have lost some of their good staff as well, and I know that the localities have benefited from that as well as have other organisations. Yeah, but whether or not there's been a real explicit sort of linking and thinking about it, I'm a little bit unsure. Yeah.
Yeah, a question. Oh, it's gone. Oh, here we go. So, what would your recommendations be for decolonising public healthcare systems?
Yeah, it's all the framing, isn't it? I mean, I think this work that Healthy Families has been trying to do could be cast as decolonising. So yeah, difficult question without all sorts of other things.
I guess a follow-up from that is how scalable is this approach to look at a whole of service kind of, or multiple points of delivery across the motu? What kind of resourcing is required to achieve this?
Yeah, I'd love to think about it. Yeah, because I think that there's, even aside from the sort of discrete initiative, Healthy Families New Zealand, I think there's a whole lot of things which have been highlighted by the way that these teams operate, and also lessons from other parts of our health system. And I know that one of the things we haven't been very good at, when we've done reforms in the past, is that learning. And yeah, so that whole idea about reorienting our health system, it'd be interesting to look at what resources. I couldn't tell you, but I'd love to think about it for sure.
So we'll have a few minutes if there are any other questions. No late one from Duff at this time. Really disappointing things about the online conferences. You don't feel the feedback.
No, okay.
On the screen, but that was
true.
Really inspiring and excellent work. And thank you very much for bringing it to us, Anna.
Yeah, thank you very much. And thank you for all those who listened who I cannot see. Okay.
Thank you.
Lovely.
Okay, next we are up with Alexandria Mintoft-Jones from the Health Quality and Safety Commission. Alex is a data analyst there, where she analyzes data for the Patient Experience Survey. She's got a background in health epidemiology and pharmacy, and an enduring interest in public health and equity. And today she'll be speaking to how to improve public health through decreasing meat consumption. Over to you, Alex.
Hello, sorry. I'm assuming you can hear me now. Okay.
Yes, loud and clear.
Great. Let me just. Okay. Can you see my presentation?
Yes.
Okay, great. Okay, thank you. Yes, so my talk is going to be on how to improve public health through decreasing meat consumption. So the project that this talk was based on was a review of reviews of literature looking at interventions that decreased meat consumption. Well, actually all animal product consumption, but I'm just going to be talking about meat consumption because that was where there was the most literature on. So I'll first be talking about what is the public health case for reducing meat consumption. So why should people interested in public health care about the amount of meat that New Zealanders are consuming? And then we'll be talking about the actual study, how we did the literature review, and what interventions are shown to have an impact on reducing meat consumption. So the first point I'm going to make is about individual health. So red meat is a class 2 carcinogen by the World Health Organization, which means it's a probable carcinogen, and processed meat is a class 1 carcinogen, meaning it's a known human carcinogen. Other long-term conditions that are correlated with high meat consumption include heart disease and diabetes, largely due to the cholesterol and saturated fat content of meat. So excess meat consumption causes a lot of unnecessary long-term health conditions. Second point is weight management, which is obviously related to heart disease and diabetes. Thanks to a New Zealand-based randomized controlled trial on plant-based plant-based diet, this is now a recommended weight management technique, is to have a plant-based diet. This is mostly because of the fiber content of plant foods compared to meat. And yeah, because of these risks, health guidelines, dietary guidelines, such as those from the World Health Organization and from Harvard Medical School, recommend reduction of or elimination of meat products for optimal health. So globally, this is from the World Health Organization's burden of disease study. There's you can see the number of deaths in 2015 from a diet. This all caused deaths from a diet high in meat, in red meat, was around 850,000, and from deaths attributable to a diet high in processed meat was about 250,000 unnecessary deaths attributable to this product. And in terms of disabilities, about 22 million disability adjusted life years attributable to meat consumption. In New Zealand, it was about 1,000 deaths in 2015. In 1990, it was about 4% of deaths were attributable to diets high in red meat consumption, and also high amounts of, again, disability adjusted life years from diets in red meat consumption, diets high in red meat consumption. The second public health reason for wanting to reduce meat consumption is environmental health, so climate change and air pollution. There's lots of causes of both of these problems, obviously, but in terms of food production, 80% of pollutants created by food are animal in origin in the US, and there's just a much higher impact on the climate of animal products compared to plant products. So looking at air pollution specifically, this is air pollution indoor and outdoor from all air pollutants, obviously. This is the third highest cause of risk factor for deaths in the world, and the highest cause of environmental related deaths. In New Zealand, it was a lot lower than that, but still air pollution contributing to a number of deaths annually in New Zealand. These are deaths from increases in long-term conditions such as lung cancer, strokes, and heart disease. It's estimated that over 90% of the world's population breathe unhealthy air, and New Zealand is not a exception to that. This is a caption from Wellington. The third reason is work-related injuries, muscular injuries. According to ACC, the slaughterhouse and meat production have higher rates of workplace injuries compared to other forms of food production. So that's, yeah, things like sprains and strains, or cutting, amputations, things like that. And there's also a larger amount of major trauma caused by animals on farms compared to like other protein production. The fourth reason is pandemics and outbreaks. So on small scales, obviously, contaminants, feces in the water, causing outbreaks and causing death that happens in New Zealand every so often, but also internationally, pandemics. HIV is thought to be caused by bushmeat consumption of apes. Mad cow disease, obviously caused by production of cows, and suspected that COVID was caused by also animal product consumption, as over 70% of new human diseases are animal in origin, and obviously eating animals causes increased risk of pandemics that have massive death tolls and causes massive amounts of disability. I'm just going to briefly talk about health equity. There's a higher burden of cancer and heart disease for certain ethnic groups in New Zealand, and traditional diets tend to have less consumption of animal products, higher consumption of vegetable products. In the American literature, there's a something called a Hispanic paradox, which is that Hispanic people in America tend to have higher tend to have larger life expectancies than white populations, despite being lower income, and this is attributable to firstly to having less smoking in the population, but secondly to having significantly healthier diets than the general population in America, over such that the discrimination and unfair treatment from the health system they get doesn't cause as much, such that their diets overcame that reduction in health life expectancy. So this is not found in second generation Hispanic people because of the adoption of diets that are higher in meat products in children of immigrants. So there's a number of causes of obviously of why the standard American diet is detrimental, but one of them is the higher consumption of meat products. Also, deaths from pandemics and workplace injuries have a higher burden on ethnic minorities in this country, and also predicted that the effects of climate change and air pollution are going to be higher on certain communities than others. So if we're caring about a health equity standpoint and from a perspective of trying to embrace traditional knowledge systems, a decrease in meat consumption is beneficial. So given these public health risks and also other reasons that people are interested in reducing meat consumption, we did a meta review, which is a review of reviews of literature reviews of studies, interventions that were shown to cause a reduction in meat consumption. So the process of this meta review is that a systematic literature review is where you look at all of the studies that are related to a certain topic, and then look at what all of those studies say as a whole. That causes that process is called a systematic review. And then a meta review is where you look at all of those systematic reviews and see from an even higher perspective what studies are shown to what studies are shown to cause a reduction in meat product consumption. So our research question was, what interventions influence animal product consumption, influence either increase or decrease. So what we found from that was there was a number of studies that looked at providing information of the environmental consequences and of the health consequences of meat consumption. So from a public health perspective or from an individual clinician perspective, providing information about the health consequences of excess meat consumption in patients is shown to be beneficial. There was more high confidence that it was beneficial, which was that there was more than 8 studies supporting the intervention. In general, behaviour change is difficult. Any kind of habit change is difficult, but especially dietary change due to cultural reasons, norms, perhaps not having cooking skills of different products. General behaviour change principles focus on things like norms and defaults. So a norm being what do most people do in your community, a default being the thing that's the most easy to do. And in both of these cases, high animal product consumption is the norm and is a default. So because of that, they're emphasizing changing norms around meat consumption is the only way that you can use this behavior change principle. So this is just some data from the UK showing that there has been an increase in vegetarianism, veganism, and decrease in people who identify as meat eaters over the past few years. So this is changing. One of the things we found that didn't work was economic interventions. So that's either decreasing the price of meat or increasing the price of vegetables. Both of those were not found to be effective at the prices that were looked at. So this was a full list of interventions that are found to be recommended because of our study. In terms of the defaults, offering smaller portions of meat at restaurants and at supermarkets is found to decrease meat product consumption. Okay, that's all. Thank you very much.
Thank you very much, Alex. I was really interested in those first charts you put up where there was in deaths and delis, where there was a gradual decline through to, I can't remember what time period, but a strong acceleration or increase.
Yeah, in New Zealand.
Are those explained?
No, I couldn't find anything for looking at why that is, and I don't know why it would be in New Zealand that that's the case versus in globally it's just gone up, 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 up. So yeah, I don't know about that. Sorry, I did try to look.
Okay, thank you. Questions from the floor. How can we engage in culturally considerate conversations about diets that are heavily influenced by meat consumption without relying solely on high-level statistics and numbers?
Yeah, well, I think that it would depend on what cultures specifically you're talking about, but as I said, for the most part, traditional diets have had much lower rates of meat consumption and higher rates of vegetable and bean consumption than our current diets do. So I would, yeah, if I was talking to someone, I would probably focus on that, on trying to look at traditional diets and focusing on just traditional diets. Also, there's some recommendations about just like swapping half of your meat in a meal with another protein source, so that it's not changing the recipe a whole lot. Is that what you're talking about? I'm not sure what the question was.
Might have a follow-up from Dixie there. Your slide's still on screen, by the way, Alex.
Oh, yeah.
Somewhat more like a collaborative approach. What Dixie was looking towards. Yeah, engaging people, everyone at the table. It's a good pun. Yeah, so do you want me to re-ask that? So how do you engage communities in whānau in a cultural Māori Pacifica considerate conversation to make these change without resorting to the statistics solely?
Yeah, so I would say I would probably focus on traditional diets and how they traditional recipes and things like that, and how they the increase in meat consumption is largely a Western phenomena.
It'd be interesting if the Healthy Families New Zealand is engaging diet and getting the voices of the community through that program. Yeah. Okay, any other questions from the floor? It's no.
I think there's something someone said about
Yes, we do have a couple of questions in the Q&A
Yeah.
for you, Alexandria.
Oh,
A question from
nice.
Emily, who wonders how these results would apply to the New Zealand situation where livestock farming has such a big social and economic role.
Yeah, so I think it's something like 60% of the GDP in New Zealand is due to animal products. So that's including meat, dairy, eggs, honey, and shellfish. So it's a massive, massive part of our GDP. So changing that is certainly not going to be something that happens quickly, I would say. I think the interventions that have been done in New Zealand that show that the public health benefits, the individual health benefits of reducing meat consumption show that it's not, it's not a crazy thing for New Zealanders to be thinking about this. But yeah, in terms of the economics, I really don't know how to answer that question because it's such a massive part of our GDP. I really don't think that it will change overnight. I mean, obviously the economy can and has changed, but we wouldn't be able to drop such a massive part of our global output just overnight. So is that what you're talking about? Yeah. It's a really big percentage of our GDP.
Anything else, Patrick?
Yeah, one more question there. Thanks for your presentation. I'm surprised you didn't find more on economic instruments. Did many studies evaluate food taxes and subsidies?
Yeah, I think a few have, and at least at the prices that were looked at, didn't find that it decreased meat products consumption. So it's possible that at higher prices it would. But yeah, that was also found. That's also been found for vegetable consumption, that subsidies of vegetable didn't increase the amount that people purchase them. So yeah, I don't know why that is. I know that that's found to be to work for, like, sugar tax has been shown to decrease sugar consumption and stuff like that, but it wasn't found in when we looked at vegetable, the research that I've seen on vegetable and meat consumption.
Anything else, Patrick? I've just noticed that my Q&A box is disconnected and keeps trying to reconnect, so I can't see anything in the Q&A. So you'll have to.
That's unfortunate, but there are no more questions. An anonymous contributor has dropped a link with a relevant paper in, which I think I'll share in the general chat in case it's interesting to anybody, but there are no more questions.
Hey, great. Thank you very much, Alex. I think my lunch was so suitably informed by your discussion, and really appreciate you presenting today. And we will now call up Paul Keymer. I'm not sure if I pronounced that surname correctly, but from Te Whatuora. He's currently the National Quarantine Capability Manager and previously worked in managed isolation and quarantine space supporting New Zealand's COVID-19 response, and focus of which was ensuring strategic, future-looking advice was in play across the response. And today he'll be speaking to the topic of fusing intelligence and strategy, the MIQ experience. So I welcome Paul to take the screen.
Thank you, Ron. I'm just going to screen share.
We've got your notes. Is it screen? Yep, that's the one.
Thanks, Ron. Hopefully you can just see the slide now.
Yes.
Great. Tēnā koutou mā, ko Paul Keymer toka ingoa, I mihi atu ki te haukanga, te ati awa, me te hapuri, koutou e nohu ana, ke wainga, nui a tātou, nā mihi atu. Hello everyone, I'm Paul Keymer, good pronunciation, thanks Ron. I am the National Quarantine Capability Manager in Te Whatu Ora as of about 2 weeks ago, and previously was the manager of the Future Strategies team in MIQ. Just to say, for a point of clarity, this presentation, it doesn't represent the views of Te Whatu Ora or MB. The views are mine, and it's actually separate to my day-to-day role. Open with a quote. Essentially, governments need to demonstrate the same level of political will, ambition, and international cooperation that leaders demonstrated in the wake of World War II when they coalesced around the objective of a sustainable peace. This must be applied in the post-pandemic order because at its heart, health security is national security. And that's a little indicator to my background, more on that in a while. The aim for today really was building from an article I wrote for the National Security Journal with colleagues on our MIQ experience, fusing intelligence and strategy. But to take it a step further today, my message will attempt to make a compelling case for a health-focused strategic futures capability, comprising some of the critical planning, intelligence and coordination functions needed to prepare public health for potential plausible and preferred future scenarios. Very interested to hear the talks earlier in the day from Mat Walton and Matheson around complex theory, and actually some of these future scenarios that I suppose we want to forget about, but actually we need to plan for. So this is making a pitch at a capability which could do some of that thinking. I'm going to talk you through our experience in MIQ and fusing those functions, how we configured some examples of our outputs, but then crucially balance that out with what we learned and what does it mean for the future. That is where I'm going to make my case for this capability. Another point I would say, this is neither a critique of MIQ nor really advocating it as a successful response. That's not the aim of today, but it is very useful context for this journey. So we were a small team of intelligence and strategy advisors. Intelligence is my background, and a number of the team that we brought on board, really to provide strategic advice. 7 people. We focused on medium-term planning. Anyone familiar with MIQ will know that the long-term plan effectively was for tomorrow rather than other strategic contexts. We wrote special interest reports, bracket intelligence reports, conducted investment planning, monitored global best practice and threat awareness. Threat primarily, of course, in this situation was COVID-19. To point out, we were established late in the COVID-19 or MIQ's journey. So September 21, I was brought on board and recruited for the rest of the year and effectively achieved full operating capability in January 2022. And by May 2022, we had finished. Our members effectively worked elsewhere. But this microcosm, this role was unique, in my view, because of MIQ's unique experience in building a functional capability that we really didn't have just a few months earlier. So how do we provide advice? How do we leverage intelligence? How do we create better decisions in this environment? You can see a couple of the definitions at the bottom there of strategic planning, intelligence, and data analysis, which I'm not going to go through now, but which are available in the slide in the presentation afterwards. So the concepts, inputs, intelligence, the knowledge requirement, the start point for your intelligence cycle. Give me direction, give me questions to answer. I will go away, I'll collect the information, fuse the information such that I can provide decision makers advice on anticipated futures according to likelihood, probability, severity. And you know, how when we move into the strategy space here in blue, well, how does that affect my decision making, and what's the high level plan I'm coming up with here? What's the advice I'm providing decision makers such that we can make the plan, but then looping back into the intelligence to monitor the effectiveness of the plan. We heard about lots of data issues earlier, data analysis. The intelligence part of this team was closely linked to the data team in MIQ, which was excellent. A point I will make later is that it could have been even tighter. But also those intelligence outputs, if we configure them appropriately, can test that high level plan and advice that we're providing. So I'm going to talk through some of the outputs briefly. There's quite a lot of scenario generation to start with. So taking you back to November, December 2021, we're in the midst of our Delta outbreak. Omicron has about to be discovered, and of course incur into New Zealand early 2022. This particular scenario, I'm noting that there are many different ways to do scenarios, was for a program business case. This was making the case for investment in MIQ next. What do we need? Well, it needs to be something that is able to configure or mitigate against the most pessimistic of scenarios, potentially, whilst considering the most optimistic. And you can see how we've laid some of the drivers out there. This was Jan 22. This was when Omicron was known, but it hadn't necessarily incurred in the community in New Zealand. And this was our scenario generation configured around these 5 drivers. So the international situation, policy settings, health situation, MIQ situation, and domestic experience. What do we think is going to happen? I will say that there are robust processes that allowed us to derive these scenarios, and that they contributed to decision makers, but also policy and planning in MIQ to good effect. In terms of presenting the information, we quickly learned that we needed to visualize and cater for time poor decision makers. So this was a summary of those 3 scenarios, again, according to the drivers. So we've got our contained, situation manageable, our significant impact, some systems failing, and then the catastrophic impact, some systems failing, most systems failing. 3 weeks after we were pulling this together, we wanted to publish it, and we thought, blimey, the situation has changed so rapidly that we need to provide an update. Hence what is the reality on the ground today, and then some of the potential flashpoints. So I mentioned the unique novel nature of the team, and we're really starting to play with some of the intelligence practices that we had learned through our careers. Next step was to demonstrate, well, where are we? You know, from a near real-time perspective, which scenario do we think that we're in, and where do we think we're going? So what we did is, again, mention of the fusion of qualitative and quantitative data earlier to make assessment. That's what we're doing. So some of the drivers that sit behind this overall assessment look like this. So working left to right, My computer's about to restart, don't want that. Working left to right, you have your driver being that domestic situation, health system capacity, and then we're looking at the indicators that we want to measure or assess. And then we have some warnings that are going to be red flags, or we're going to want to elevate and escalate to decision makers. And then our data sources, so that we know where we're getting this information from, if we need to hand over the work or for audit processes down the line. In terms of, again, presenting this on a weekly basis, we did not present this slide. Rather, we presented something that looks like this. So taking those indicators and saying, okay, the orange cross is where we sit at the moment. The grey cross is where we were the last reporting period. And then the orange dashed line with arrow is where we think we're going. So this is where the intelligence is coming in and the fusion with data. The remaining 4 drivers here. So inequity, again, we've heard lots about equity. We were asked to deliver an intelligence report on Aotearoa New Zealand's inequity of experience. And really, all of a sudden, we were unpacking an issue that, hands up, we hadn't really considered previously. We needed to consider. And we came up with a model of how we assessed where it was and where it was going, which looked like this. You know, we've got our quantitative indicators. We know we can get some numbers there, but what about the qualitative indicators, which you can see far outnumber the quantitative in this case? We then said how the indicators were tracking over time according to our scenarios. That's this graph here. Further to the inequity of experience, you can see that we thought that we were doing reasonably well. 14th of Feb, when we first started reporting this. And what I want to say about the green line really is the more work we put into understanding the inequity of experience felt through our population, the more we realized that actually we're closer to catastrophic here. And so the third case study I wanted to gloss through is using the scenarios to conduct tabletop exercises for the purposes of investment planning. So what we wanted to do was to create 5 diseases, which were what we called fake but feasible. They're imaginary diseases, but they are rooted in diseases that we know about, of course. They are communicable diseases. They are diseases where quarantine is an effective mitigating factor. So non-pharmaceutical interventions apply here. We then created environmental factors around each of the scenarios so that we could start playing with social license, with health system capacity, and some of the drivers actually in the earlier scenarios that I presented. So we had a series of workshops. We had a public sector workshop where we had about 14 agencies represented around the table. We had an independent adjudicator, and essentially we presented the scenario in March 2025, so that we were only a couple of years away. The health system had not changed immeasurably, unrecognisably. And we, you could say, are still in the COVID era. So we are familiar with the lessons of COVID. Disease Benedict occurs into New Zealand. We talk through the situation. We then go around these agencies and give them 2 minutes to say, what are you doing? What are your priorities? How are you configuring resource? Interesting exercise, which we followed with the private sector, and largely they were private sector organisations who had been involved in COVID-19 response and who it could be envisaged might be involved in the future. And this was some of the outcomes by sector, and then where they joined in the middle. So rapid activation of plans, fast and consistent communications, strong relationships in place before crisis, lots of outputs or recommendations that I'm fairly sure would be familiar with and would not be particularly new or novel. next slide concerns the importance of timely actions, however. I think in New Zealand we were lucky, certainly when it comes to considering the rest of the world and how timely actions, and I'm largely speaking about non-pharmaceutical interventions, quarantine, social distancing, etc., but how quickly they were implemented. I found this academic article, which note the date being May 2020, so it was early in the pandemic. But you know, if China had introduced non-pharmaceutical interventions earlier than it did by a week, 2 weeks, or even 3 weeks, just look at the reduction in the number of cases. 1 week earlier, reducing the number of cases in China by 66%. Another week, another 2 weeks, reducing to 86 and 95%. Retrospectively. That says to me, you know, if we're configuring a system, albeit, you know, beholden to political direction, but if we're considering a system that could activate quickly in the future, that's going to give us the ability to reduce cases from the outset. So that's the end of the case studies. This is kind of part 2 of the presentation. What did we learn? We learned a heap about the uniqueness of the environment which we found ourselves in. We had autonomy, I would say, to a large degree, to play with and fuse business functions capabilities that ordinarily in another organization you might find siloed in larger teams. This really does, I think, play into the presentation that Mat Walton gave earlier. In terms of viable systems and how it's configured. Another thing that worked well was senior level advocation, sponsorship. You know, you need your decision makers to say, I require better decision advice, decision support. What are we planning for in the future? Prepare me. So that worked well because we did have that. Largely through a guy called Andy Milne, who was the Associate Deputy Secretary in MIQ at the time. What could we do differently? Well, I mentioned the timeframes earlier. We were brought in September 21, and that's when our first person was recruited. It took 3 months to become fully operational. I would say, really, you need a capability like this from the outset. Although I will say that the MB Intelligence Unit did provide some inputs pre-September 21. Second point, functional fusion. The ability to bring together aligned functions, I will say. So planning, intelligence, coordination, really, really useful. I'm going to go on to advocate the inclusion of futures studies, brackets, foresight, and I'll talk to you a bit about that in the future. But the scenario generation that I took you through, you know, extrapolating that forward again would be extremely useful for better planning, resource allocation. The links with the data team were good. I, in reflection, felt that we could have done a better job of making sure those relationships were tighter. There was limited health intelligence experience. Now, being a career intelligence person, I would say that you can apply intelligence to any area of interest, but certainly it would help, I think, in this particular instance and in the future if you have others who have an awareness of health, because of course we do have health intelligence capabilities in place at the moment. So, what does this all mean? My view is that New Zealand needs a strategic futures capability to challenge and foster better long-term planning. I think it's widely acknowledged, and I'm not going out on a limb to say that in New Zealand, our strategic long-term planning is an issue. And you can look into why that is, but ultimately I think we should be positioning ourselves to do it better. I think the capability should be enduring, well-resourced and centrally positioned such that it might provide advice outwards. And it must be able to plan for complex, complicated, chaotic futures. Again, all the points that Anna made earlier. And another point that Anna made was around connecting national and local governments to communities and how we actually put into play some of the highfalutin strategies and plans that we have in the centre ground at the local level, which seems to be the wrong way to do it. But if you had a strategic capability if you had a strategic futures capability that was able to facilitate conversations with communities and at the local level, that would greatly enhance integration and buy-in to what we might propose at the national level. Other countries have something a little similar, particularly Singapore. Singapore always seemed to have the gold-plated solution to issues that I look at, but they have a Centre for Strategic Studies here. You know, it's a whole of government strategic planning, prioritisation, coordination function sitting in their Prime Minister's office. Fantastic. The European Commission as well have this centralised kind of function, leading their efforts to embed strategic foresight across their work, so they're planning for that future. So my apologies for the lack of graphic design here, but really what I'm saying here is intelligence and future studies complement each other nicely. Future studies or foresight definition you can see in the top right. I advocate for a particular brand of this called the 6 Pillars approach, which is a methodology that you step through really to understand what the long-term future could be in terms of the causal layer analysis. So why could this future present? But in quite an aspirational way. You know, it's a positive way. It's well, we think the future could look like this, and actually then we're going to work out how we arrive at this aspired future destination. So there's quite a lot of why in there, which really helps us drive the strategy. But from an intelligence perspective, we're almost looking at threats and risks predominantly in the near term, often leveraging current or historical information and extrapolating that forward. So what are our kind of short-term trends? Again, to an earlier slide, the concept, what is the likelihood, probability that this short-term future will arise? The strategy here you can see is actually the critical linkage between those two. So the concept that I'm proposing is a little updated from the earlier concept, and you can see the addition of foresight future studies there. And I've termed that intended outcomes. This is what we want to happen, fusing it with the intelligence aspect here of unintended outcomes or threats and risks and what that might look like, to develop a holistic plan and then into the strategy space. Again, just to reiterate, functional fusion, I believe, is powerful where it can be achieved. And especially when we're talking about engaging and providing the structures and frameworks to have conversations around these chaotic, complex, potentially complicated futures. And then we can then plan for that in the long term, in the strategy space, but actually provide almost near real-time reporting from the intelligence data analysis perspective on how we're doing and how we're tracking and how we're making progress towards those aspired futures. A last point here would be, I've talked a lot about the functional makeup of the team. It would be wrong of me to not consider the actual diversity in teams, which I've seen kind of change, I suppose, over the years, but just to acknowledge that the more diverse in terms of representation, and I do mean backgrounds, geographic representation, ethnicity, sexuality, economic, demographics, the more diverse, the better here. So that concludes my talk for now. There's a reference there to the the article I mentioned up top, which unpacks a little more the MIQ experience of fusing intelligence and strategy. And again, I'll share the presentation, but there's some links here to some of my references. One thing I didn't particularly mention, which strikes me as I look at the DPMC Futures Thinking, actually, is the current state of futures thinking foresight in New Zealand, which is relatively, how would I describe it? A bit of a cottage industry, if I'm being, hopefully not being unfair. Various agencies tend to set up small projects and pull in some expertise here, but there is no central really coordinating function. DPMC on that futures thinking page provides a bit of connectivity and advice on how it can be applied, but it's not widespread. Okay, that was a real rattle through. I thought I was not going to have enough time. I've probably gone through too quickly, but Ron, thanks very much for the time, and open to questions.
Thank you very much, Paul. Completely tautaku your view on the diversity in the intel space across skills and people. It's something we need to achieve, I think, for a fully functional organization. I don't recall if it was prior to the 2009 swine flu or afterwards, but I do recall there being a discussion and a working group stood up around developing MIQ type facilities. Obviously it didn't get very far at that time. And so the question is, for me then, if we're talking about public health events like COVID, like these things that are very high impact, but quite low probability, how do you sustain investment and capability over the time periods that between these things? Because it's very easy to erode budgets and teams as other priorities pop up.
Well, thanks, Ron. That's a great question, and that basically reflects the last 2 years of my life. You know, we've been on a journey which, when we were in the acute stage of COVID-19, we felt very much the pressure to make the investment case for permanent quarantine and isolation facilities, the likes of which that you saw established in Australia. I think it's fair to say we're still making the investment case for how we deliver non-pharmaceutical interventions for communicable disease right now. And my view is you're right. Whilst we need to maintain some sort of ability to protect ourselves from a global pandemic, I see the focus switching to lower investment around workforces at the community level, you know, raising education awareness around simple non-pharmaceutical interventions that we can do to really limit outbreaks becoming epidemics and epidemics becoming pandemics. So there's this kind of switch from drawbridges are up. We're trying to restrict the movement of travellers into New Zealand such that we can keep this communicable disease at bay. To retain that, yeah, okay, in some small capacity, which doesn't represent significant, regretful investment. But actually, how do we do it better at home? How do we protect our individuals, our whānau better? And we're looking at cost-effective ways of doing that, but that actually really is the focus. So I was very interested to hear from Anna around the Healthy Families New Zealand, for example, and the local community connections with some of those service providers and some of the local organisations represented in some of those hubs, because I see potential there for what we're trying to achieve.
Yeah, second, I think it's more of a comment rather than a question. Is during COVID and other responses, I sit in the public health service sphere, and I had no idea what the kind of intel reporting you guys are putting out that you were demonstrating, and it kind of would have been great to have had that connection. It just shows how disconnected some of these things are.
I think you're totally right. That each agency reverted to type and conducted their own insights and intelligence reporting. There was a DPMC COVID-19 group who attempted, to coordinate some of the intel reporting across government, and they did a great job of it, but we're really kind of pushing uphill. Some of the reason for that, I think, was capacity, because it remained, in terms of resourcing, resources were stretched. We had reasonable capacity, but a lot of our stuff was focused on MIQ. When we invited, so the Omicron scenario generation that we did, for example, we invited in an all of government audience, and I think a lot of the other agencies were like, fantastic, someone else has the time to configure something up and will produce outputs that we can receive down the line. So the relevance of your topic is important, I think, because people wanted to jump on some of the sessions we facilitated in the outputs. But again, going back to Matt's conversation earlier, that coordination piece is so critical. From a COVID perspective, it really was changing by the hour almost. So the intelligence providing that ground up experience, with ministers needing to know about individual tests, and the tactical nature of what we were doing was quite incredible, really, in terms of the distance between the strategic and the tactical. And I think that's the main reason why it took so long for a capability of this nature to be established in MIQ, because everything was tactical, timeframes were compressed, and it took quite a long time to recognize, actually, we do need to create this kind of ring-fence capability to think about what's beyond next week.
So you provided a good segue into one of the questions in the Q&A, and that is there a recognized definition of intelligence compared to, say, research, insights, and evaluation?
I'll take insights first. My view on insights is, and I'm sure I'm going to get shot down, but that's okay. I'll just go with it. Insights, I often connected closely to data and quantitative analysis. So if I present a chart or a graph with numbers, that might be data. Well, insights tells a story about what's actually going on there. What it does not do is extrapolate that into the future and say, okay, well, if this continues, or it is highly likely that this might continue for the following reasons. However, a worse course of action might be X. That's really the intelligence space. Evaluation research, probably stepping well away from my comfort zone there, if I'm perfectly honest. I have a very short stab at research, which I guess is kind of building on that data and insights, but kind of testing hypotheses to understand a bit more about the insights. Maybe insights is a relatively compressed analytical process, whereas research, of course, can go on and is extremely robust. I'll stop there.
Fairly decent crack, I think. Another question from floor. What did you learn about inequity and how it presents when running a public health system?
We learned lots, and I think it was throughout MIQ being such, well, maybe not controversial at the time, but certainly as time progresses, maybe controversial because of its nature, and when you start to look at the Bill of Rights and restricting people's freedom effectively, are you doing that in a just and ethical way? This became particularly an issue when MIQ started taking community cases as opposed to case international travellers effectively, because there were different needs. of those. If you imagine that an international traveller might be someone that's used to international travel and had the planning time to book MIQ and to know through others' experience what MIQ might be. So there's a preparation period, whereas in the community, people were often taken into MIQ at very short notice with their whānau and into these hotel rooms, which weren't particularly well configured to the needs of family groups. You then start to consider culturally how we approached that service delivery and whether we could have done that better, such that we could cater for individuals' cultural needs. Yeah, and that's kind of just the start, I would say. When we looked at inequities of experience in the Intel report I mentioned, we essentially looked at the effect of COVID-19 on priority populations and vulnerable groups. So I think they included Maori, Pacific communities in New Zealand, Asian New Zealanders, rural, young, and the elderly, I think, from memory, and just looked at the impact through COVID's through the COVID era, if you like, of how those groups were disproportionately impacted. And I'd have to refer to the report to bring up some of the lessons there, and they'd be quite detailed, but it was a really useful experience. And again, I'm not sure across government how much focus was being put on that. So it was useful.
Hey, I'm not seeing, oh, another one. I can see them now, Patrick. Comment here, sounds like this post-COVID period is a good time to develop some generic epidemic imitation model accounting for New Zealand geo-demo connectivity, etc.
I mean, I totally agree with that. And that essentially brings us up to date into my current role and what we're doing from a non-pharmaceutical intervention perspective, to focus on the individual and whānau and communities, such that they could protect themselves and have the wraparound services they need to break transmission pathways of communicable disease. And using scenarios, you know, measles, tuberculosis, whatever we might be looking at as the preeminent threat, but also novel pathogens into the future, how they might present, you know, our classic disease X. And just to talk over the disease X book that I put in my references was particularly insightful in that perspective, although configured largely around establishing vaccination programs. Yeah. It's kind of where we are at the moment, but absolutely agree with that statement.
Another question, how, when, where do you identify and address inaccuracies in the data or acknowledge the poor quality of data, which is often the case with administrative health data? Say, not often, maybe always.
Yeah. Where do I, that is, again, like it's a fantastic point. I think I put better data integration into my concept, but certainly data quality, connectivity across the health systems and other systems across government, and how you ethically leverage that data. Again, we heard earlier about that is an issue, you know, and it's probably always going to be an issue. But we need to do the best we can effectively. And that's where the relationship, I think, with the data team or integrating a data team into this sort of concept for a strategic futures capability would be important, even if it's just to identify the limitations and the deficiencies in the data, even if you're not going to get better data. I think that's important. So thank you, Wiruwai. That's a great question.
That might be it. Last calls. No. So I'm going to be handing over to someone to close this out. Is that you, Barry? Oh, you're on mute.
Thank you, Ron. Well done. Well done, everyone. Now ask Tim to do the closing. Thank you all the presenters today. Excellent job. And I think we're delighted with the quality of the presentations and also that they've hit the mark exactly on the theme that we've been looking for. So it's been an outstanding success today. And I'd like to thank everybody that's participated in it. So pass back to Tim to do the closing karakia.
Mihi, thank you, Barry, and thank you, Ron and Patrick, for your work today. Mi karakia tātou, unihau, mihau ki te uru tapanui, he wātea, he mama, he nākau, ki tiana, te wauru. E te ara tākata, kia rā o rongo, akakiri aki kia ranga, kia tina, ina, huie, pai kia. Bye, thank you.
Thank you, Tim. And that brings the Wednesday session to a close. And thank you once again for your attendance, and thank you to the presenters. And we look forward to you joining us tomorrow at 9 a.m. with first two overseas speakers from England. So thank you very much. Can the members of the steering group still around, can you stay on while everybody else logs off just for a quick chat? Thank you. Thank you, everyone.